morning, everyone. Bonjour. My name is Valbona Zanelli. I'm a senior fellow with Friends of Europe. Thank you very much to everyone for being here this morning and this very rainy day, which is usual for Brussels, I would say. I kept saying that every time that I was in Brussels, it was sunshine to a friend just 2 days ago, so I think I jinxed it. It is a pleasure to see such a distinguished group of policymakers, healthcare professionals, researchers, industry leaders, and civil society representatives coming here today, gathering here today to discuss one of the defining challenges of our time: how to build health systems that are more resilient, more equitable, more innovative, and also sustainable. So the title of the conference, Reimagining Europe's Health Systems, it's very, very timely. And I think what is even more important is having this diverse group of people coming together, because usually when we talk about these topics, we talk in our own circles, we talk in silos, and we do not exchange the very much needed information to bring change. Over the past few years, Europe's healthcare systems have faced unprecedented pressures. It was just 5 years ago, or a little bit more, the COVID-19 pandemic that exposed vulnerabilities that many of us had long recognized that existed, but perhaps we had underestimated. The problem is that what we see in Europe, we act upon crisis. So that was the main priority 5 years ago, 6 years ago. Now it looks like we're back to business as usual, and we have lost that sense of urgency, that sense of speed in order to take the necessary actions for reform. At the same time, demographic change, workforce shortages in the healthcare system, rising healthcare costs, the growing burden of chronic diseases, and rapid technological transformation are fundamentally reshaping the healthcare landscape, not only in Europe, but globally. Yet, these challenges also represent very big opportunities. Across Europe, we're witnessing remarkable advances in digital health, artificial intelligence, personalized medicine, and data-driven healthcare. And we'll discuss some of these topics today, also starting this panel. New approaches to prevention, patient-centered care, and cross-border cooperation offer the potential to improve outcomes while strengthening the resilience of our health systems. The question before us today is not simply how to repair the existing systems. The question is how to reimagine the systems for the years and decades to come. And so, as you'll see in the program of the conference, we have raised some questions here for the first panel. But really, I mean, how can Europe ensure universal access to high-quality care while maintaining financial sustainability? How can innovation be harnessed in a way that benefits all citizens? How can policymakers, healthcare providers, industry, patients work together to create really a system that is fit for the challenges of this century? To help us with these questions, but even more, we are fortunate to be joined by an outstanding panel of experts who bring diverse perspectives and deep experience across the healthcare system. So with us today, we have online the alternate Minister of Health of Greece, Ms. Irini Agapidaki. Do you hear us? Okay, great. Wonderful to have. We wished you were here in person, but we're grateful for your time that you are with us online. Ms. Florica Fink-Hoyer, the European Commission Director General for Health, Emergency Preparedness and Response Authority. Thank you for being here with us today. Rob Deby, Business Development Leader, Critical Care Europe at Philip. Thank you very much. And thank you for partnering with Friends of Europe to make this conference possible. Marilena Vrana, Vice President of Public Affairs and EU Operation with the Plasma Protein Therapeutics Association. Thank you for being here with us today. So we have so many questions to unlock in just less than 1 hour now of time. But what I would like to do before we go to the real, questions that you saw in the agenda, I'd like to start with a very quick round. Minister, I'd like to ask you to respond in less than 30 seconds. What do you see as the main challenge for the health systems in Europe today and the main opportunity? And then we'll do that with the rest of the panel. One challenge, one opportunity.
Okay. The most important challenge, I think, and thank you for the opportunity to contribute to this discussion even remotely. Number one challenge is the shortage that we have in personnel. The healthcare personnel professions are not that attractive anymore, and we need to reframe the way we work across the health systems across Europe. And the asset, the opportunity is absolutely the digital health and AI era that we can actually develop tools that can support clinical decision-making, can make the time of healthcare personnel more valuable, more effective, more efficient.
Well, thank you very much. Florica, what is the biggest challenge?
Thank you, and good morning to everybody. First of all, I would definitely agree with the minister, but let me bring in another perspective. We all know here in Brussels, we are ahead of the MFF discussions. So one of the big challenges is that health and health infrastructure would not be seen as important anymore because we have other, of course, competing priorities, but health should be seen as a critical infrastructure and as critical assets. The challenge, I'm sorry that I say that, is never waste a crisis, and we have two crises ongoing, Hunter and Ebola, and that might be a wake-up call, which could become an opportunity in these debates.
Thank you. Rob?
Good morning, everybody, and thank you for having me. I'm going to echo the same thing, indeed. It's shortage of staff, but the shortage of staff is not only for the healthcare system. It's across the board. I think within our healthcare system, what we're lacking is the road towards digitization and make uses of that AI. If you compare that to our personal lives, we're much further ahead. We're a little bit hesitant, I think, within the healthcare systems. For me, there lies the biggest opportunity to cover.
Thank you. Marilena.
Thank you for having me as well. I will echo all of the previous speakers on the challenge. The main challenge that we are facing in the healthcare systems is a continuous and growing pressures that they have, whether they are from crisis or whether they are from lack of personnel or economic constraints also. So that is combined with increasing disease burden, etc. This is a lot to handle. And in terms of opportunity, generally we do have a growing political willingness to see resilience and sustainability in the systems. That's an opportunity not to be forgotten, but with it, we really need to rethink what do we have, and in the diversity of the approaches that all the member states have, what are good elements that can be transferred in other systems and how we can leverage the diversity that we have already across the systems.
Thank you very much. So I think Marilena covered more than one challenge with her response, talking also about the fragmentation of the systems, of the health system more broadly in Europe. Minister, I'll come back to you. You mentioned shortages in personnel. And we know that the shortage of trained healthcare professionals across Europe is now is a critical threat for everyone. If you look at really at data, it's really, scaring. The WHO projects a shortage of, can you hear me? I think the mic, okay, yes. Projects a shortage of 4.1 million healthcare workers in the EU by 2030. Already the EU is insured at least of 1.2 million doctors. These are not just numbers. These are patients that are not served at the hospital. This means it's related directly to the physical security and safety of people. So what can Europe realistically do to improve the supply of healthcare workers?
Well, I'm not really sure that the shortages, the lack of personnel that we have, or the projections about the healthcare personnel that we will have the next few years reflects or implies that we won't be able to cover the needs of the population. I mean, by taking into account the example that we have in Greece, the case of Greece, we have used the mobile health units that are staffed with doctors, nurses, health visitors, which means that we use other health professionals, not just the doctor. As you know, in Greece, we have a doctor-centered system, a hospital-centered system, which is actually not still, I would say, efficient anymore. That's why we have shifted to prevention. That's why we invest more on try to have primary, secondary prevention, and try actually not just to train the patients and the citizens to seek help when they are ill, but actually how they can avoid illness, how can they avoid sickness. This is, I think, the game changer for the next few years. Otherwise, I mean, if public health fails, because this is actually a matter of public health, it's not just a medical issue. So if public health fails, there is no way that medicine can manage to address all these needs across Europe. This is one thing. And the second thing has to do with climate crisis and the implication to the general population and all the other geopolitical changes that we actually experience all this time. So I think that we have an interrelated issue that we need to consider together, not just to rethink the health system itself, but try to consider the ecosystem that the health system is actually a key driver for health, wellness, and quality of life. I think this is the differentiation that we need to make nowadays and try to reshape health systems in a way that integrates AI for the benefit of the population, for the benefit of doctors, nurses, the healthcare professionals in general. Try to make all these digital tools usable, accessible, valuable, affordable. Try to make new treatments and new drugs available and affordable for across the EU territory. So I think this is the most important thing, not just to focus on the personnel shortages and that the absence, let's say, or the decline of healthcare personnel implies automatically less, services for the population. This is not true. We have alternative tools that we can use and make the time, as I said before, of healthcare professionals more valuable and more efficient. But on the other hand, we need to reconsider the health system itself as a pillar of the society, because as it stands, I would say across the EU is outdated.
Mm-hmm. Great point, Minister. So, I mean, you started with the shortage of personnel as the main challenge. Mm-hmm. Do you think still this issue in the European Union is treated as a staffing issue and it's not really seen as a strategic resilience function? I mean, you mentioned healthcare as a pillar of the society. Even when we talk about geopolitics or even when we talk about the competitiveness of the European Union, are we treating the health systems as part of that?
I think you have answered already the question. I mean, you have highlighted the fact that we do not consider, we do not discuss health system and the health workforce as a player for the whole society, as a societal factor, but we discuss it more, typically as an aspect of the health system and health system performance. I think we talk with an old language for nowadays challenges. This is not the framework that will allow us to make reforms, to try to shape the today's health systems in a way that will serve the needs of the population and will also serve other purposes. For example, we need to consider health diplomacy as a pillar for policymaking and politics as well. We need to consider health systems as a societal pillar, which means that it takes more than medical, more than the health aspect, more than the traditional, let's say, key constructs that are pertaining to health. We need to consider the health system as a place that people gather, develop relationships. They can also make assumptions about democracy. If someone feels that some services or some drugs are not accessible, they feel deprived, they feel that they are marginalized nowadays. And this implies directly to the voting and democratic values and behaviors, which means that health systems, health in general, not just the health system, is something more at the 21st century than the traditional, let's say, architecture of health. Mm-hmm. It's something more than the facts and the figures and the statistics. It's something that make us feel connected or disconnected, which means that make us feel part of the democratic infrastructure, part of the democratic architecture or not. So this is something that concerns me a lot. Health diplomacy and the conceptualized framework that we place health rather than the health system discussion per se.
Oh, thank you very much. And I think we'll come back to some of the topics, very interesting topics that you raised. And it's very interesting, you know, how come we kind of missed the train in the sense that 5 years ago, everything was about health systems while we were facing the pandemic. It was a huge sense of urgency in everything that we're doing. And let's not even discuss about the supply chain and the shortages that we faced. Are we preparing for the next crisis?
Well, I think a lot of work has already been done. We have the HERA mechanism, which is an achievement for the EU Commission. And also we have emergency preparedness and response mechanisms that are coordinated by ECDC and developed across many different member states, which is a success, absolutely. I would also like to highlight the fact that the Commission and Europe has made a great achievement with the joint procurement of COVID vaccines. I think this is a model that we need to take into account into shaping tomorrow's policies, because this is a way to eliminate health inequities between and within member states. We can actually ensure access and equity for many different populations across EU. So I don't think that we are there yet in terms of health system preparedness and response, but we are actually making important progress, and we can make a lot more if we can try to coordinate, not just theoretically, but also on the field.
Well, thank you. The minister mentioned a lot, and everybody also in the panel talked about the AI and the new the role of medical technology, and of course, critical care Europe at Philips has a very important role when it comes to new developments. So, what would you say, Rob, when it comes to how do you help? How does industry, more in general, helps in creating this resilient framework in the health systems of Europe? And what do you see as the main opportunities out there?
Yeah, good question. And coming back to my starting point again, right? The word AI is used a lot, and so do we within Philips. But we look at it as a holy grail, which solves all our problems. But the usage of AI is so important. AI, for me, is an enabler. It's more what you do with it. But before you get to the position of AI, you need to get the data out. So everybody talks about AI. AI is going to solve it. But the majority of some countries in Europe don't even have an EMR, right? They work on paper charts. So we're not digitalized across Europe. We are in Sweden, as an example, right? Very mature market already. So is the Netherlands. But it's not across. So the starting point for me would be get the data out of the systems, out of the Philips systems, but also from other tech companies with ventilators, perfusion pumps, and what's not. Once you have that data, then you need to standardize it even. because all these different companies, they talk their proprietary languages. So that means you need to standardize the data so everybody understands what you can build upon that. And AI is a little bit further out for me when it comes to patient monitoring data. We do great things, I think, with imaging already. There's the usage of AI already quite matured. But on continuous data for monitoring patients in and outside the hospital, it's not there yet. So the first step is, you already mentioned a little bit, I think, the clinical decision support, right? So just a decision tree based on data. So where can Philips help? In digitalize hospitals, making sure you get the data out of the systems, not only out of our own systems, but also from other vendors. That data needs to be shared.
Well, data issue is always a big issue in Europe, though. How do you overcome those hurdles?
So, indeed, right?
If I go somewhere, I have to fill out like 20, 30 papers just on the data privacy issues.
But then again, we're already talking about North Star. Even sharing data within a hospital domain is not common practice, right? Everybody talks about sharing data from a European health data space. We're a big fan of that. But there's so many steps to take in between that the European health data space for me is a North Star. We should move in that direction. But first, make sure that within one hospital itself, people can access the data. People talk to me like data is the new currency. Well, if that's the case, we're a leaking bucket. We're letting a lot of data leave the hospitals or not even capturing the data. Right? So if you want to build smartness on top of that, let's start first with getting the data out. That is one. On the other hand, I think as Philips and tech companies, we play a crucial role in defense, as an example. Data is one, but you also need hardware. You need equipment, you need a patient monitor, you need a mobile MRI, you need a containerized CT scan, things like that. We are capable of doing so already. One of the great examples, I think, and you already mentioned it, never waste a good crisis. For those who are not aware, we have the rescue stockpile located in the Netherlands. The rescue stockpile, it's a mobile ICU, so to say. So we can supply 1,100 ICU beds already, and we deployed it over the last couple of years already 12 times. I think these are great examples of what we can do. But now, this is only one. I think in the crisis that we are today, we need to multiply, and we need to multiply fast. Not only having a stockpile available in countries like the Netherlands, but also on the east side of Europe for faster deployments. Mm-hmm. So I think there are multiple roles for us as Philips where we can contribute in the day-to-day business, but also in the military part.
Mm-hmm. Well, thank you, Rob. Some of the points that you raised actually have been recognized in various EU communications, including the EU Preparedness Union strategies. So we all talk about how we have to move from, paperwork, from strategy into implementation. What do you see some of the main challenges in this lack of implementation of what's very well written in strategies?
Yeah. It's the obvious one, and we discussed it yesterday, and it's not the answer to every question, but it's funding and resources, in all honesty. Also, when you look at the rescue stockpile, the contract is coming to an end. It's owned by the European Commission, but the governance is done by the Ministry of Health of the Netherlands. There's always a bit of a caveat. Who is taking responsibility for what? Who's going to follow up on the contracts, right? So I think also the Ministry of Health in the Netherlands, they could use the support to get the resources available to keep the momentum going.
I mean, we always go back to funding and resources, but we all know that resources are finite. So, where should we put the resources first? Should we put them on defense? Should we put them on competitiveness? Should we put them on healthcare? Should we put them on education? How do you prioritize?
That's a very good question, I think. I think we're already working on a burning platform, right? Priority number one, I think we should treat everybody equally, right? So when somebody is going out in the battlefield, he or she deserves the same treatment as what she deserves when he or she is at home. So should we look at prioritization per different object, or should we look at the ecosystem as a whole? I'm with you. We cannot do everything at the same time. But what I started off with already is that shortages of staff is across the border. Mm-hmm. Right? It's not only in the healthcare system. It's everywhere. So prioritization needs to be done, I think, based on standardization of care across the border, across Europe, and let's take that as a starting point.
Thank you. Marilena, I mean, we're discussing a lot about also momentum in EU legislation on health issues, from the Critical Medicines Act, the Bio Act, AI Act, medical devices regulation, etc. From where you stand, do you see that as a sign that EU policymakers see health as, critical infrastructure sector, as part of the critical infrastructure sector? And you were explaining last night at dinner some of the challenges that you see inside Europe. Also, the differences inside Europe, the level of fragmentation, the transatlantic, relations as part of that. So it's going back into this bigger geopolitical environment. Tell us more.
Thank you, Valbona. In a nutshell, the answer to your question is yes. There is a growing political recognition that health is not only a social issue. The minister also explained this elaboratively. All the initiatives that you've just listed, including many others, the general pharmaceutical legislation, the SOHO regulation, which are adopted, in terms of ambition, political ambition, they do point into the same direction. Which is, as Mr. Varelli recently said in the Parliament, is a competitive, resilient Europe. Our common objective is an attractive European health ecosystem that delivers safe, effective, and affordable medicines across the member states for all patients. So the question to me is whether all of these legislations, new or revised, will help us achieve these ultimate political objectives. And to answer this question, I have three points in my mind to make. One is why is important recognizing the differences across the medicines that we already have. Two, why we need to see innovation more broadly. And three, why, for our case, which you mentioned, dependency, why we need to lower our dependency from third countries, which for plasma-derived medicines is our dependency in the United States. So let me first start with the differences between medicines. We do have a European critical medicines list that includes 270 medicines. All of these, as you understand, do not share the same supply chains, do not share the same materials, and certainly they do not depend on the same manufacturing processes. So one size cannot fit all, this is clear. So then we need to pay attention to that. So if our legislations will be effective in the end, will depend whether they will reflect the diversity of the healthcare systems that we have and the diversity of manufacturing chains that we have in place. Let me give you an example from the plasma-derived medicine, so it's a bit more clear. Plasma-derived medicines, unlike many other traditional medicines that we know, do not depend on chemical substances, but they do depend on human plasma that can only be donated from healthy individuals. So we cannot build factories to develop plasma. In this human substance, we can only rely on good collection mechanisms. I don't know in this room if anyone has ever donated plasma or even knows what plasma donation is. So on top of that, we need collecting the plasma. On top of that, we do have complex manufacturing supply chains that apply many different legislative frameworks that take very long. We need about 12 months for a medicine to be developed. And here's now also one memorable fact in terms of economics. From 1 liter of plasma, the companies can manufacture around 20 different medicines, just from 1 liter. And these different medicines can save the lives of different patients living with genetic, chronic diseases. This is why it's important in legislation to reflect this diversity and in the implementation phases to always keep in mind these facts. Now, my second point on innovation. Innovation, we tend to think about innovation about novel technologies, novel treatment. However, innovation doesn't stop when a new therapy or a new medical device is into the market. There is a continuous investment on innovation to improve manufacturing processes, to improve collection processes in our sector, at least. So innovation needs to be recognized inside the Biotech Act, for example, right now, more broadly to cover the whole value chain of medicine. Now, my third and final point is on European strategic autonomy, and in this we will enter a little bit on geopolitics and giving...
we cannot escape.
Yeah. Reducing vulnerabilities, we all agree, is a common objective. We really need to do that. And in the case of plasma-derived medicines, the dependency of the European Union to the United States is still quite high. Roughly 40%, depending on the year. We need to import plasma from the United States for manufacturing.
But why
medicines.
is the United States doing that better? What are the lessons learned there?
Well,
we have many questions for you.
Yes. The United States, as well as 4 member states in the European Union, are managing to collect far more plasma than any other countries because they do have a coexistence model. They do have the private sector, non-profit sector, and the public sector operating efficiently alongside each other for the same purpose. And this is working. Mm-hmm. They do use the coexistence, and they have scaled up the use of plasmapheresis, which is a procedure where only the plasma is donated, while the rest of the blood components return safely to the donor. Mm-hmm. It's an easy process, it's a safe process, and it's more efficient for collecting plasma for manufacturing medicines than blood collections. So this tells us something important, all of this that we just said, including the model that you mentioned. First, to lower our vulnerabilities, we need to collect more plasma. In our case, we really need to look at where our dependencies are and do more. We need to leverage the capabilities of all the actors, the private sector, the public sector, and the nonprofit. We all have different capabilities on offering into the systems. And last but not least, we need to collectively raise awareness on the needs that the systems have. In our case, collectively raise awareness, what is plasma donation, why it's valuable, why it's needed, and scale it up more.
Well, thank you very much. So now, Florica, all the questions come to you from the European Commission. So we have seen that most of the times the European Union has been reacting well, but on different crises, starting from the COVID-19 pandemic. Now we've seen that, you know, the European Union's capacity to address health threats was again tested by the recent hantavirus outbreak on a cruise ship. So in terms of the Health Emergency Preparedness and Response Authority that you lead, how would you explain what is happening in Europe? I think part of, for the bigger public, is that we're missing some important work that's being done. So how would you, communicate with the public what is the European Commission doing in terms of increasing resilience of Europeans?
Thank you. It's a very long question, but I will try to be short nevertheless. Take Hanta. The hantavirus, in principle, that would have been the perfect storm, right? 23 different nationalities. They could have embarked everywhere. They could have gone everywhere, and not having been spotted, not traced, no contact tracing, everything. I think the hantavirus, for me, really showed that Europe is much better prepared now, because we managed to contain. Nobody's speaking about it anymore, but we do have patients in many countries here. But what happened was we had excellent recommendations and protocols from the ECDC. We had a very good cooperation between WHO and ECDC and the Commission. We had excellent member states' responsibilities, taking a lead, taking responsibilities, showing exemplary discipline in accepting and living these protocols. So now we don't hear much about it, although these patients are still in isolation, but so far it's contained. They are still, because it's a long incubation time, still new patients coming. But we, of course, as HERA, for instance, also don't forget there is no vaccine, there is no treatment. This is a deadly virus. It's a contact virus. It's fortunately not a respiratory virus, otherwise it would have been much bigger, but it is still a deadly virus. And we have managed to nevertheless deliver to the member states some what we call investigational therapies, and we will see. But for the moment it's contained, and that's very good. Now take Ebola. Again, I would say the preparedness, especially also from the European side, had paid a little bit off in the sense that the genomic sequencing capacity that we spread out as capacity building in Africa helped to identify the Andes variant, no, not the Andes virus, that was Santa, but the Bundibugyo virus. Why? Because if it wouldn't have been identified through this capacity building, it would have taken even longer. Now, it has taken far too long, I'm absolutely with you, but the world is stepping up. I think the lessons learned of a pandemic, a global pandemic, is very much ingrained in many countries, and they are stepping up. But of course, here we are in Ebola in a situation where it is a conflict zone. Access is the issue. It's not the issue of not having the diagnostics on which everybody is chipping in, or the workforce, which is also missing, but it's a very difficult setup. But in general, I would say preparedness has been increased. I would never say it's there 100%, but the mechanisms in order to detect, to know what to do, and also even on vaccines and so on, development are there. I can talk about that in a minute. But you talked also, and I wanted to go back to what others have said about the geopolitics. The geopolitics has, of course, an influence on competitiveness here, on AI here, but very much also on the global health system, because health has become quite transactional for some, and has become actually a geopolitical lever for access to raw materials, for voting rights in wherever international community. So that's where I think the European Union also wants to give a different model. We have the Global Health Resilience Initiative, which we just had published, and where we really advocate for an open and transparent system, which is ingrained in national responsibilities, wherever it is, from Africa to Asia, but an open system. And also delivering the capacity, because for me, what is very important if you want to have health systems working, it's a structural preparedness from the very start. You don't have a response at the end. You start by preparing, and that's a structural, costly investment in order to avoid something. And that's exactly what happened also with Hunter and other things. Now, I'm trying to also respond a little bit of what was said. The minister called it health diplomacy. Thank you very much for that, because without having had networks on, for instance, with Japan and SCARA, we wouldn't have been able to now also deliver certain antivirals for to the member states in the hantavirus crisis. So this is also a structural preparedness which is paying off. You have to build this up in peacetime. This is about trust. You cannot just say, oh, I actually need something. Why? Who are you? Nobody would come. So that's also important. But others, like Rob mentioned, the security nexus with health, very important one, because we also have another geopolitical threat, which is Ukraine, the war in Ukraine, not Ukraine, but the war in Ukraine, the Russian war in Ukraine. And of course, this influences what we do in Europe on health systems. From the health emergency position, we are very much investing, of course, in CBRN, in armed conflicts, in having the medical countermeasures ready for mass casualties or hybrid attacks, right? So this is part of this nexus on which we also have to prepare. And that brings me to the other one that you have said, the economic autonomy, the security, the economic security, which is about supply chains. If you just make the link with armed conflicts, obviously plasma, but also antibiotics would be a big issue for us, and it is. You mentioned the rescue stockpiles. Indeed, HERA has set up for, I don't know, several billion a stockpile across Europe in different member states, also in the Netherlands, and we need to replenish them. But we need to replenish them now with, that's why I said about the MFF, with new fresh money, because this is going now towards the end. And we need to replenish that according to the new threats scenarios, which are still pandemics, which are vector-borne diseases linked to climate change, is AMR, and is, of course, armed conflicts. So for that, you need a manufacturing capacity also in Europe. For that, you need to identify the supply chain vulnerabilities. For instance, we were just looking Iran conflict. What does it mean for us on medical countermeasures? These are the things which is, for me, preparedness. It doesn't mean that it comes tomorrow, but you need to invest in analysis, but also in structural preparedness, which means the end-to-end approach. You have to really look along the way what you can prepare.
Well, thank you very much. Thank you very much, Florica, for covering in very comprehensive way all the ground. Minister, the Greek minister, Agapidaki, she has to leave for another commitment. So I'll just like to give you the floor 1 minute if you want to respond to something that your fellow panelists mentioned, please.
Thank you so much. What Florica has already highlighted is music to my ears. It's very important to understand that there is a time window between having a threat that is invisible, but we get prepared for the case that will be visible, and we need to tackle it. So the Commission is still working and working well and makes good progress on all these different aspects. I was really, really happy to hear straight and clearly that we work towards the hybrid attacks, bioterrorism included. This is a public health response, public health preparedness aspect. But just to conclude and try to include also the initial aspects we have discussed today, I also need to highlight that framing health system as a cost and pressure topic is no longer adequate. Health systems are not expenditure items. They are critical infrastructure for productivity, social cohesion, preparedness, and ultimately, the resilience of our economies. This is why the question before us today is so important, and the starting point should acknowledge the demographic reality and changes across Europe. I would like also to highlight the fact that Greece has managed with this huge, and I would say reform about prevention to bridge the gap with other member states for all these decades and make a reality a robust, efficient, effective prevention system for all. This is how we have managed to reach more than 6 million citizens that they had their medical checkups, no matter of their social insurance status. So we tackle inequities this way. We increase trust to the health system, to the Ministry of Health, to the different institutions, to democracy at the end of the day. And it's important because we invest in people's lives, we do not just do work differently. We think differently about health, not just the health systems, and we do differently to impact not just health, but social cohesion as well. Thank you so much. I apologize for not being able to stay with you longer. Thank you so much for this opportunity.
Well, thank you very much for being with us. Thank you for your time, and thank you for your great comments. We'll see you next time. So I'd like to go back to Florica. You mentioned really very good points, and we know that the European Commission has taken the lead in Europe among the other EU institutions when it comes to European security, when it comes to defense, when it comes to competitiveness, when it comes to industrial policy. So my question is, where is health there in this environment? Where does it stand? we all talk about the single market now, which is the big, thing. Are we thinking about a single market in the health systems? When we talk about fragmentation, we actually look at from the positive perspective of diversities in the European Union. But when I think about diseases, when I think about prevention, I think it's more universal, not just inside the European Union, but also more globally. So where does health stand in this strategic autonomy and competitiveness of the European Union? Are we going to have an industrial policy on health? I'll ask the question directly.
It's a very difficult question to answer, but let's say health, of course, is an ecosystem on its own. And you have, the minister mentioned it, you have to strengthen the hospitals, the workforce, and so on and so on. I come from emergency help. So, of course, health is a national responsibility. It's a national prerogative. And therefore, whether or not the systems have a uniform approach or different approach, that's national. And it's also linked into their reimbursement system, let's face it, very much. But from if you go to a more higher level of threats, like what we do, like the health emergency threats, then this system is looking a little bit different, and we would really plead for saying that if you want to be resilient, you need to have structural preparedness. And that goes along what we call the end-to-end approach. We had that in the medical countermeasure strategy, where and I would like to perhaps briefly run that through. I mean, the end-to-end approach starts by surveillance. We have different surveillance systems. Obviously, in Europe, we are very happy to have the ECDC. But we're also investing, for instance, as HERA, into wastewater surveillance systems, not just in Europe, but also rolling that out in Asia, in Africa, and now in Latin America. That costs a little bit, but it's not that much. It's actually very simple. We're also financing the WHO hub in Berlin because we want all these different layers of information to come together, and these are data, so that we have early detection, early signals, and perhaps trends that are becoming aware. So that's the surveillance. The first part is surveillance and detection. Then you have to accelerate development. You called it innovation, quite rightly so. But there we all know about the valley of death and all of this. They are big challenges, especially for small and medium-sized companies. We are working with the EIB on that. We are working with what we call now an accelerator, so as to bring the entire chain also through clinical trials and so on until it comes to the market, so as to have a market. You mentioned the single market in that sense. I would just give one example. We had just recently a discussion of the upcoming Public Procurement Act, right? And one of the questions is buy Europe or not buy Europe and all of this. When you look at what we will want to do as Commission, there's many things that in HERA we do already: innovative procurement, competitive procurement, these type of things. But at the same time, also by Europe, we definitely can that in emergency times. We have even specific regulations that would allow us to ask your industry to push aside and just go on that. But that doesn't help. Because how can you have a response if you haven't catered for a market before? Because if not, you might not even have an industry producing exactly what you would need in that crisis. So I explained that we have, throughout the year, somebody mentioned joint procurement. Throughout the year, for more than 32 participants, we can launch joint procurements, and we do in double-digit numbers contracts. But this is important in order not just to have something ready, but also to keep a market, right? When we have reservation contracts, which we called EOFAB, this is about to keep a manufacturing capacity warm, as we say it, in order to be able to scale up in case of. And that's where we also now look at what we call ramp up. It's called, well, it's a bit like that to make it attractive, but it's about a partnership, a rapid manufacturing partnership with industry. We work with almost all industries, European, non-European, but most of them have also, they are established here as well, in order to know who can provide what for what type of crisis we work mainly with 4 big crisis scenarios, and also where would they be ready to do a tech transfer, because that is also needed. So these are structural forms, and then you go also on reinforcing cooperation, for instance. I talked about a little bit about international cooperation, but it also goes for civil society, which we have a forum, but it also goes for industrial cooperation. We need to have this dialogue constantly in order to know where we have these vulnerabilities, and then to see what mechanisms, innovative mechanisms we could do, be it in financing mechanisms or in structural support, in order to have this end-to-end pipeline.
Thank you very much. I have so many more questions for you, but I will give the floor to the public, to the audience, for about 5 minutes, so maybe we'll be able to take 3 questions. Please, quick questions for the panelists. Anyone would like to start? Please. Can you bring the microphone here, please? If you can briefly introduce yourself and then quickly to the question.
Sure. My name is Zoe Dingwall. I'm here on behalf of JERP, one of your sponsors today. My question is really for Rob and Florica. While there's no doubt that the digital transformation and artificial intelligence will certainly bring efficiencies, they also bring some strategic vulnerabilities to our medicine supply system. So what happens when you can't get the actual data out of the system? I'm thinking mainly in the case of a CBRNE incident. You know, do we have any disaster or resilience exercises foreseen? Thank you.
Thank you. Other questions? Please.
Yes, thank you for this really interesting presentation. So my name is Björk Paulsdottir from the Training for Health Equity Network. I'm very curious to see what, in terms of preparation and prevention, how do we ensure and build and maintain public trust in institution and in healthcare as a part of that systems approach?
Mm-hmm. Thank you. Gentleman there.
Hello, my name is for Care for Everybody. My question is, how come we don't hear about the quality of healthcare for women? While we know if we take that seriously and improve the quality of healthcare for women, European economy could grow with over 5% competitivity.
Mm-hmm. Thank you very much. So maybe we will start with Florica.
Well, I can react a bit on the first question. Obviously, AI has very wonderful opportunities for us. When we know, we work with biolabs who will now look and run through supercomputers some of the antivirals in order to see, can we repurpose them, for instance, for Ebola. Positive. The dark side is obviously biosecurity, on which we are not enough prepared, but other geopolitical partners are preparing massively for that. So we are seeing that, and we are also going into that. Now, your question on, do we have CBRN exercise? Yes, we do. We have actually one this coming up, which will be embedded also in a NATO exercise. So that we do. On public trust, I would also like to say just a few words. This is the biggest challenge. I mean, you asked us in the beginning of bigger challenge. For me, I'm always thinking like we might have, let's say, we would always have thought not about Ebola or Hunter. We thought about avian flu, right? Very dangerous because it's a respiratory pandemic, could be when it is mutating from human to human. And then the big issue is, as we see already even in Ebola now, but that is different cultural backgrounds and community issues, is about even if we were to have a countermeasure, would people take it? Or would they say, like in COVID, no, we don't? So, and then if they don't take, you cannot contain. If it is a very, very respiratory, very dangerous pandemic. So this is a big challenge. We are working, obviously, with member states. We're working with ECDC, because I think fact-based information is still very important. It should not be brushed aside. But you need, if you really want to work on that, go much deeper to community leaders, to those who can convince. This is not about just facts and figures. But if you don't have the facts and figures right, and you would say everything is completely different from what it is, the facts and figures, then already we have a starting problem. But we take that very serious as well, and we try to work on recommendations with member states. But ultimately, this is a very broad discussion also for our democracy, because in a pandemic, it will absolutely be abused by certain third countries as well in order to undermine stability, trust in governments, and so on and so on. So it's clear.
Thank you. Rob?
Yeah, I would like to respond also to the AI question, mainly because if you're going to use AI on big data sets, we need to go to cloud. Cloud adoption in Europe for healthcare systems is not a standard yet, mainly also because of the geopolitical situation that we're in. Right? The big cloud drivers are coming from the US. So therefore, as Philips, we're also looking at, can we deploy it on-prem? Although if you want to go for scale, also for us as a company, to keep it safe, to keep it updated, to keep it cyber secure, cloud is the way forward for us. Although we fully understand the position that we're in today. So cloud will come. It needs a little bit more time, we expect. So we're looking in ways how we can mitigate that time gap. But I would encourage everybody to really think about cloud for healthcare systems. We're so used to it in our personal life. Everything we have running on our phone is cloud-based. So all the data is already out there. I can get into your bank accounts if I want to. But when it comes to our healthcare data, we're a little bit hesitant, which I fully understand by all good meanings. But we really need to think about cloud adoption for our healthcare society as well.
Thank you, Rob.
Thank you.
Marilena?
Yeah, thank you. I'll just make a quick comment on the trust aspect.
Which is connected, I think, with
yes,
Rob.
yes, certainly. So yeah, the minister also mentioned that health diplomacy is a part of structural preparedness, and it does relate to trust. So trust is not something that we just earn or you can take for granted, but it takes a continuous effort to build it. So mechanisms where all the stakeholders continuously come to the table and discuss the common challenges and potential solutions, learn from each other, what has worked well in some member states, what is not working in others, and how to tackle that is a way where we can increase trust between stakeholders and ultimately with society, including on data, sharing our data or not. So that's something we need to keep developing.
Great. So since you have the mic, I'll go for the last round. We started at the beginning with challenges and opportunities. Now my question will be, if there is one decision that the policymakers should take in the next year, in the next 12 months, what should that be in order to really be serious in treating health system as a part of the critical infrastructure of Europe? That one decision.
That's a great question, and I would have hoped the minister was here to answer this for us as well. As I said before, there is one size will not fit, does not fit everything. So if they, how to prioritize and what they need to think about is to make sure that they approach way forward implementing legislation and decisions with more realism. I mean, the political ambitions are nice and very good to hear, but we also need to be practical. We are not going to decrease our vulnerabilities overnight. We have built actually our vulnerabilities in the past decades. So we need to take time, be flexible, tailor the implementation of the legislations that we have in place, or build in flexibility to the legislation that we are still negotiating. So when we are implementing it, we do take into account what is the specific problem that we are trying to face, be it on infectious diseases, on rare diseases, on chronic diseases, and then adapt implementation to the problem. So flexibility for realistic implementation.
Thank you. Rob, the same question for you.
Yeah. I have two answers, if that's okay. One is
We'll take it.
keep the momentum going in what we're doing very well. Right? I think we should be very proud of where we stand as Europe. We have amazing tech companies across Europe, not only Philips, also companies like Hamilton, Gating, B. Brown. We have a lot. Keep that momentum going, and let's deliver upon the things like the stockpiling that we're doing very well. On the other side, let's help those communities that are not digitalized. Let's make sure that they're getting into the matureness level of the rest of Europe to really start saving time from our clinicians, from our nursing staff, by using data-driven decision support and eventually AI on continuous monitoring data.
Thank you. Florica?
If health systems are seen as critical infrastructure for Europe's competitiveness, then my suggestion would be mainstream that across all the policies, be it finance, be it defense, be it competitiveness, be it single market, then mainstream health as a critical infrastructure, as a strategic asset for Europe.
Absolutely. And actually, one of the questions for you was that, will we see, maybe in the future, also health ministers coming together with defense ministers and finance minister and discuss? It goes into the mainstreaming point that you had. So maybe that's where we need to start. So thank you very much. I'd like to thank our panelists for opening up the conversation that will continue in the next few panels. Thank you for being with us. And thank you for the work that you do day in, day out to make our health system better. Thank you. I think we have a coffee break now. No coffee break. Okay. Thank you.
Thanks, everyone. I'm sorry to be the bearer of bad news. You will not get coffee just yet. My name is Nina Raval. I'm the second moderator of today, and we will switch gears. There's a little of switching going on. In the meantime, I'll welcome my panelists onto the stage. Welcome. Hi, nice to meet you. Hi, Nina, good to meet you. All right, I think we are ready to get back. I'll ask people to keep the chatting for the coffee in the next break, which will be after this session. In this session, and I want to say actually thank you, some speakers were notified today jumping in. So you might think that I'm going to make it easier on you, we will see. But I'm sure you will live up to it anyway. In this session, we heard in the opening session about the various pressures and crises that Europe has faced over the past years, from pandemics to shortage of staff and innovation and whatnot. And in this session, we're going to take a harder look at what that means for Europe going forward. So beyond the suite of crises, it's more like permanent pressure. And that permanent pressure calls for a new type of architecture where it isn't crisis and fire extinguishing mode, but rather planning for how we manage these permanent pressures. So with us to do that, like I mentioned, we have a suite of speakers that represent different perspectives. And it was supposed to be a member of parliament, but we're very lucky. He is unfortunately not feeling well. So instead, we have, let me see now, excuse me, we have Ms. Danai Spensu, who is the head of cabinet for a member of parliament, Andreas Kulja. And I would like to start with you, since you are the newcomer to this party. We will give you the stage first. Now, in the previous session, we talked about AI, and I guess we are all in a situation where no matter which room we are, we talk about AI in one shape or form. So, given this need for handling pressure for shortage of staff, whatnot, what we heard in the previous session, if you were to talk about and identify the policy decisions that Europe should be taking today, so that AI actually enables healthcare workers to do what they do rather than simply replace them, what would that be?
Hello, everyone. Hello. So yes, apologies for the last moment change. MEP Kulia and I were working together on the report that is happening now in the European Parliament about the healthcare workforce shortages. And a very big part of this report is actually addressing AI and digitalization. When we talk about AI today, we have to see it as an amazing tool that can bring us great innovation and can help address the shortages we have from different levels and issues. It can reduce times, administrative pressure. It can help bring back motivation to many of healthcare workers that they feel that they're losing this in the bad working conditions, long hours, stress, and it can actually remotivate them and bring them to focus on the issues that matter the most and bring them more issues, more interest. But in order to do all that, indeed, Europe has to regulate this framework in a way that it's ethical. It always has, as we say, there are different languages, and what we agreed on this text now is human in command and human in control. So we always have the human-centric approach when we're dealing with AI, and when, especially on the healthcare sector, when we approach this. So the policy framework has always to put it as a complementary sector and then always to have the human in the center and responsible. We need to have also regulations that are actually enabling the development of AI, so such as regulatory sandboxes we see in different legislative initiatives now. We saw it a bit in the general pharma legislation. Now we will have the biotech legislation that they allow for a lot of regulatory sandboxes to help develop the way that the technology is also developing at the same path. And we need also to provide AI algorithms that are non-biased, as we insert all the data information the same way that human might be biased, the same way the AI might end up being biased. So unbiased structure is very, very important, and policy and EU healthcare policy should be focusing on that for sure.
And may I ask you to just give a little bit color to the tension between the human in the loop or human at the center of decision making? If you look at Asia, for example, they have taken another route, generally speaking, really looking to that scaling opportunity of AI, especially in the light of healthcare shortages or not access or whatnot. Do you want to give some color to summarizing the debate on the pros and cons of having that human at the center?
Yes, absolutely. Indeed, as you stated, like in Asia, we have a very different approach than Europe, but this is always the case. We were also the first continent to actually have an horizontal AI act and legislation dealing with it. Even though it's not specifically focused on the healthcare sector, of course, it then is implemented on the healthcare sector. When we're talking about human in the loop and AI, people sometimes can always misinterpret and being misinformed on what is actually meaning. So we want human to be the ones that they're making the final decisions when we're talking about strategic policy and the important decision. We want human to be, they will be the ones deciding, as they cannot have, the AI yet has some levels of improvement, but cannot have this level of decision making at any point. So it's very important to keep this human-centric access and position on every topic, and it is indeed discussed on what level will the human influence will be maintained or not. But it seems that in the European level, at least, and what the Commission proposed on the ethical guidelines for the AI, we will very much keep always this human-centric approach close in the center.
Mm-hmm. Thank you. We're going to hold that thought. We're going to move on to the next new speaker. Welcome, Edward Alexander James Smith. It's not Torte. Got to be dynamic here at Friends of Europe. And you, let me find your title. You are head of EU policy for the Ministry of Interior and Health in Denmark. So most welcome. Now, Denmark is often seen as a country that connects health policy, life science, digitalization, public sector, small and nimble and dynamic, right? And you made some recent reform to healthcare services where you look at some of the things we've been talking about yesterday and today, prevention, digital health, integrated care systems, right? Do you see lessons, if you were to extract, I'm sure you could talk at length about this, but if you were to extract kind of the key lessons for other European countries that are looking to do the same, what would they be?
Thanks very much. And just to say that, unfortunately, Dorte couldn't join us today because we are going to get a new government in Denmark tomorrow, so she had to remain in Copenhagen, and I was already here, so I was given the opportunity to speak today, so thank you for that. Yeah, so in Denmark, we are in the process of carrying out a health reform, and this is really very much based on the idea that we really have to adapt our health systems to the changing world that we live in. And this is not only geopolitical changes, but especially with innovation, technological development, and the changing requirements of patients, and the challenges that patients face. And of course, really the changing demographics of our societies. So when we think, at least in Denmark, of designing healthcare systems that can withstand external pressures, we must think more broadly and not just focus on one or two issues and how they affect our healthcare systems. It's a number of influences coming in at the same time that we have to address. So in Denmark, we saw the need for a structural reform if we were to ensure that we could provide world-class universal healthcare to all our citizens wherever they live in Denmark. And it's especially this equal access to healthcare services that we really needed to rethink the structure of our healthcare system itself. As a health in Denmark, this universal access is really, it's a key political issue that doesn't matter how far left or how far right you are on the system, that is a political holy cow. So there's no discussion of privatizing healthcare systems in Denmark. It's universal access that is the political holy cow on this. But there had been a reform in 2004 where Denmark had organized a healthcare around 5 regions and had strengthened the hospital sector especially. But and this provided a marked increase in the quality of service or healthcare in the hospitals, but it had also, over time, had created some growing inequality, and especially rural districts, country districts, became increasingly underserved. Their waiting times diverged, and access to GPs became inadequate in many parts of the country. And that this reform had primarily helped those living near a major hospital in the capital region. So this had to be addressed if we were to ensure that our healthcare system would continue to be able to deliver the service that patients were asking for. So there were many difficult decisions to be made, and the need for reform really was recognized politically, and we reached a very broad political agreement in the parliament that to carry out this reform and what was required. And I think this is, if you really want to know what helps ensuring a robust healthcare system, is that ensuring you have a broad political agreement on which direction the healthcare system should go, so that it makes it so that you're not having a chopping and changing every time you have a change in government. This is really something that is essential if you want to have a resilient healthcare system. But the initiatives that were taken, they were quite difficult politically. That one was to reduce the number of regions from 5 to 4, and this was really to integrate the capital region into other parts of the country, so that in some way the benefits of having the capital was spread out more equally, and also in that means that you provide. You can't have doctors just being in the capital, then they're in a wider region, so they can be pushed around more within one area. So, but the main issue was really to remove resources closer to the patient, move closer towards primary care, municipalities, and care delivered in the patient's own home. And this was really a deliberate rebalancing of where care takes place and where responsibility resides. And this was especially important considering many of the challenges that have been mentioned today with availability of health staff and etc. So it introduces dedicated pathways for citizens living with chronic conditions, alongside a new principle of responsibility, so that once a patient enters the system, someone always holds responsibility for their continued care, and this of course requires quite a high level of digitalization, which we also heard about earlier. And so this core function is really committed to protecting continuity of care for every citizen, regardless of the postcode where they live. So even though you have the right structure and clear responsibilities, the systems that cannot absorb and scale innovation, they will eventually fall behind and not be able to handle the pressures that we're facing. So this is where the reforms governance changes have really become critical. Established a Digital Healthcare Denmark, which is a new national body responsible for coordinating digitalization across the healthcare system. And we heard this repeatedly from Philips in the previous session, that previously each region had its own digital solution, and this resulted in fragmentation, incompatibility, and significant duplication of investments. And so creating a single digital hub will improve the healthcare for patients. And there's also creating a National Center for Health Innovation, which is designed specifically to move promising technologies from pilot projects into clinical practice, which, as we know, is where many innovation fails. So when on innovation, we believe that public-private partnerships are essential if patients are to benefit from the most advanced forms of healthcare. And we have a growing ecosystem of health technology firms in Denmark that we deeply integrate into our research infrastructure and our clinical trial networks. And this close proximity of public and private actors really creates opportunities for patients. It shouldn't be something we believe that healthcare systems shouldn't be nervous about working with industry. It is a symbiotic relationship that can really improve our healthcare systems. And so this is really not that markets should run healthcare systems, but a well-governed public system is better positioned to leverage private innovation than fragmented ones, and this is a benefit for patients in Denmark and hopefully over time across Europe. Okay. So, but once again, just to say that the best resilience is broad political agreement and recognizing innovation as opportunity and not as a challenge, and also pressurizing your own healthcare system to embrace innovation rather than to push it away.
Excellent. So I'm going to summarize. There was a lot in there. There was access for equity. There was the long-term, trying to secure the long-term by broader political coalition, approaching reduced governance complexity by reducing the number of regions, and then views on innovations. I think there was a lot in there in terms of new architecture. We're going to come back to that, but also for now, move on. Heading to Alexander Horn. You were supposed to be here, and you're here, so thank you for that.
I'm glad that it worked out.
And you are the President and General Manager for the Germany Hub at Eli Lilly. Busy days for you guys. I want to ask you, coming from then the innovation side of the table, you operate across every major European market and healthcare system. So where have you seen a system that actually doesn't break? And you can say Denmark, but you'll say something more because we just heard Denmark. Where do you see examples of healthcare systems that absorb pressure without breaking? And what do they do that the rest of us can learn from?
No, thank you, and hello everyone. I'm very happy to be here. Yeah, let me kick us off with reminding ourselves that really a resilient healthcare system preserves the health of its society, the health of its people. And I know I state here the obvious, but when I look at different healthcare systems coming from Germany, but other countries, actually many of our healthcare systems, they are managing diseases, they're managing sick people in the system, and they're not actually intending to cure people quickly and get them out of the system. And I think there's a fundamental challenge we have. I call this, we need to move actually from sick care to health care, and really having a reform, and I'm glad you're mentioning that, where we have a fundamental paradigm shift, a really fundamental paradigm shift from what I call, again, sick care to healthcare, and that's really critical to achieve that. And obviously, those systems, to answer your questions, who are focusing on prevention do better than other systems. And I'm talking here not only about primary prevention, where we try to avoid getting people into the system, but also, and in particular, about secondary prevention. We all know that our demographic challenges are rising. With those challenges, we have more chronic diseases, and we also know that with chronic diseases, we have oftentimes really many comorbidities associated with those, and they cost a tremendous amount of money to our system. Let me illustrate this really at the example of obesity, which is a chronic disease, but associated really with 200 comorbidities like diabetes, like stroke, like heart attack. Several cancers are associated with obesity. And needless to say, if we are treating obesity early on and in an effective way, we can prevent or mitigate or reduce all those comorbidities in the system. And that's, I think, where we should go to address those comorbidities early on and in a more effective way. And of course, the patient plays also a very important role. And I'm advocating also for changing our incentive systems to have more accountability at the patient level, because we need to have better nutrition, we need to have more physical exercise, certainly also better medication early on, but this triad is, for me, the winning triad to really make our systems more reliable and more resilient. And let me add one last comment, which is also a very important one. I think what we are suffering from is always this short-term view, this short-term look at the treatment cost. We need to come to a more mid-term to long-term perspective. We need to look at diseases from a more holistic approach, taking into consideration also the direct and the indirect cost to make really the right treatment decisions and to make the right investment decisions to make the systems more resilient as they are of today.
Excellent. So the other word of the day is, of course, prevention. We're going to come back to that, I'm sure. Also something about moving from activity-based to value-based and the incentive structure. Lots to pick on there. But we are going to move before we come back. And you are also fairly new to the panel. So welcome. Nice to have you, Francis de Drey. You are the CEO of Partenamen. Yeah, thank you. Sorry. So it's in the insurance space. Yes. Belgium has perhaps one of the most complex healthcare governance structures in Europe. You have the federal, the regional, the community, with partly overlapping competencies. So I'm thinking if you can govern here and collaborate here, you can probably do it across 27 member states. So what does that tell you? We're operating in this market locally. What does that tell you about what we need in terms of new infrastructure, or excuse me, rather architecture, to preserve and what's the word I'm looking for? Protect us from the constant pressure.
You know, when you look at the base of a reform, of a health reform, you can see it from the perspective of a politician or a citizen or a provider or payer. If you look from a politician or maybe sometimes from the citizen, you may think it's very slow. It needs to speed up and have reform to have more results and outcomes. And when you look from the perspective of a provider or a payer, I'm at the cornerstone of these two parts. I have been a manager of hospitals for the last 10 years, and now for 1 year I'm on the payer side, on the public payer side. So in Belgium, it's not private insurance, it's public insurance. You see the system struggling with all the reforms, with the complexity of the system. And sometimes I have the impression that we forget sometimes what are the center of the system, which is the patient and the citizens. And for them, my main focus is about accessibility of care. And I want to explain that on 4 dimensions. The first one is the financial access. We may think that in Europe, healthcare it's given, it's universal, as you explained in Denmark, and practically it's the same in Belgium. We also have a universal coverage. But when you ask the citizens in Belgium, 30% of the citizens say, I delay or I deny a care last year because of financial reason, because it was too expensive. So we still have a main challenge about how we can finance the system and how we make sure it's accessible for the entire population. Mm-hmm. That's the first dimension of the accessibility. The second one, you also explained that in Denmark, is about territories. And again, you may think that Belgium is a very small country, so we don't have issue about access in terms of territories. It's false. Today, you have part of the country on which you cannot find a GP, and it's obviously on the rural side, on the landscape, but it's also urban. You have part in the big city where it's difficult to find a physician. Again, how we can make sure that the reform address this question of accessibility. The third dimension is about the transparency in terms of quality. We speak again, and Denmark is a very good example. I love to visit Denmark for the healthcare system. It's really impressive. If you look at the outcome and the transparency in terms of results, in Belgium we are very poor, especially on the French-speaking part of the country. As a citizen, you cannot know which hospital is the best to do transplants. And honestly, it's an information I want to know if I need to choose a hospital for this type of surgeries. And this challenge in terms of transparency on data and on quality is not only Belgium. You have a lot of countries in Europe which are still struggling about information on transparency and quality. So this is really something on which we need to work. And the last one, we also speak a bit about it this morning, is about delay and waiting time. Mm-hmm. We used to have a very strong system in terms of waiting time. Some people may remember 20 or 30 years ago, people from UK traveling to Belgium to get surgery because the delay in Belgium were really good. It's not true anymore. In some specialties, you may wait 3, 4, 5, 6 months to have an appointment. This needs to be addressed. If you don't address this 4 dimensions of accessibility, you can make every reform you want. You will not have the support of the population, of the citizens. Mm-hmm. That's my key takeaway in the discussion now.
And if I follow up on that, so if those 4 dimensions of accessibility is the key, what's the one kind of policy shift or legislation or whatever you would seek to address that? How do you actually go about that? Because I mean, I'm sure you'll give me the long answer of it's like changing, open outcomes registries and whatnot. But like the power move.
I will give one. We have lived in Belgium in a system where we restrained the access to the health professional system. So it was difficult and limited the number of physicians we hire every year in Belgium. We have moved like 2 years ago, so it will make times to go to another type of system. So it was a supply system. So we were limited in the number of healthcare professions. We need to move completely the system to have more and more professionals, physicians, but also other types of healthcare professionals. If you look at the figure in the US, for example, now they are promoting more and more career in health, saying that it's well paid, it's good career, it's career on which you will not have an issue about finding a job at 40, 50 or 60 years. That's something we need to push much more in Europe and to change a bit the paradigm. It was a system where we thought, maybe wrongly, but that if we would have too many physicians, it would cost too much. That was the issue in Belgium for 20 years. Now we have changed a bit to say, okay, let's educate more and more physicians. And I think this is one of the main way to resolve the issue of accessibility.
Okay, more doctors. I see. Okay, so we've now identified a set of needs, let's say, moving from sick care to prevention, increased need for transparency, healthcare professionals, still making sure that humans are the center of decision making, and so on. You also spoke to the whole set of the agenda in Denmark. That tends to be another way of saying I need something else. I need someone else to do that first, right? So you are now together kind of representing more or less the full stakeholder pool. So I want to hear, what do you need for someone else in this room? Because you guys are the main stakeholders. And what are you willing to give in return? Who wants to start? Go. Yeah?
Sorry, maybe to add something that we don't always take into consideration, because we talked about geographical challenges, infrastructure, human resource shortages. But definitely AI will help us come up with some numbers and performances and fill in some shortages that are critically there on infrastructure and number of people. But it's not only that. When we talk about healthcare, we also have to see how the patients feel. So something that I think we missed in our interventions is that information and education and how this is transmitted to the patient and the relationship between the doctor and the patient, which would be very, very important. We talked about the example of Denmark, and we said that it's very, very good example, and it's true. But I happen to have a colleague here from Denmark that she actually prefers the system in Belgium only because, or some of the reasons because the doctor asked her how she actually feels. She says that in Denmark, she has the opportunity to have an appointment for free for every issue, but it's only one issue in 20 minutes. If you have another question, you cannot refer to the doctor in the same 20 minutes. You need to book for another day this appointment.
So the empathy component and kind of the continuity of the GP-patient relationship rather than the transactional solving the problem. No, that's a good addition. Thank you. But I won't let you off the hook. You have the mic, so you'll continue with saying we've heard about these needs for healthcare systems to withstand permanent pressure. What do you need from someone in this room, meaning the stakeholders, and what are you willing to give in return? I'll give you one example to say, yeah, we talk about humans in the loop for AI, and I'm not going to argue against that, but I can also make the case, of course, of saying if you really want to scale, if you really want healthcare professionals to be the empathy person who sits with you, well, someone else needs to be the bulk of that decision-making, right? That would argue for actually letting go a little bit of the human in the loop. So what do you ask? And you don't have to choose that one, but what do you want from someone in the room for AI to scale and serve your citizens, and what are you willing to give in return?
Okay, that's a tough one, and I don't know if I'm in position to reply on that, but I think in general collaboration because we have different sectors here, also industry, public sector, private sector, policy makers, so collaboration among all of us, of course, it's always important. It's not as simple as it sounds, but it's something that we always need and we must focus on. Then we would need support and training the healthcare professionals and to have continuous training and upskilling throughout their work life because this is the only way that we can actually make advantage of their AI and digitalization. And then everything starts from communication, education, throughout the whole healthcare cycle and ecosystem we have, from the patient to the doctor to the caregivers, everyone. And something very, very important is that you talked about resilient healthcare systems. So also to have a more general approach under the One Health concept, so to connect the environment and healthcare so that the SWIFTs we made now don't only address the shortages on the healthcare, but also provide for a more holistic approach that also takes into consideration sustainability, maybe. This is what I would also like to request in general.
Okay. You're still on the request side. I'll come back to you for what you're giving, but I'll let you off the hook for now. Francis, what do you say? You're requesting 4 dimensions of improved accessibility. You can choose one or more, but what are you willing to give to get there?
Yeah, I would like to speak about data. And data exchange. I think Huop on the earlier session was speaking about data as well. Today, and it's maybe related again to our very complex system in Belgium, but the data are not circulating well in the system. And I would like to have both, I mean, the political decision and also the industry, and of course the mutualities, the payers as well, to exchange more the data on obviously on an ethical way and on a way the patient consent. But I will give you 2 examples. The first one, we are working very hard on increasing the rate of cancer screening in Belgium. That's something we are working on. And we are sending letters to all our members to go for the cervical or to go to the digestive cancer screening at the age of 50. We are continuing to send letters to people, and we don't know if they go or if they don't go to the test, because in the system we cannot access this type of data. I'm fighting a lot to have access to this data, and obviously that the mutualities, because we have some data as well, that we can share with the other part of the healthcare system. Again, for the industry, and your example about the anti-obesity drug is a very good example. We know this is a challenge in Europe. This is drugs that will cost a lot in the system. I think France decided last week to go for reimbursement for some of these drugs and for some specific case for patients. We have not taken this type of decision in Belgium yet, but it's for us a topic for discussion. How we can make sure to have a data-driven decision on anti-obesity drugs, to define the right price point and to make sure the budget of the state that will go for this type of drug will benefit to the system, will benefit to the prevention, the secondary. I fully agree with you. But that's for that, we need to be much more collaborative in how we structure and exchange data, because at the end it's public money that will be used for this type of drugs. So we need to find this type of discussion.
Thank you. Before you come in, Alexander, we're going to let the audience in very briefly, so get your thoughts ready on what you want to ask. And you guys had longer time to think, so your answers will be concise.
All right, I try. I want to answer the question through the lens of making Europe more competitive against the United States and against China. I think we need really a more innovation-friendly environment and an environment which provides a political framework of stability and predictability for investment.
And how will Eli Lilly contribute to that?
We are contributing when we see that we have a reliable environment where we can invest from a long-term perspective, that we are building at the moment manufacturing sites around Europe. We have a huge investment in Germany, about $2.5 billion right now ongoing in Alzey. We're investing in the Netherlands, $3 billion in another manufacturing site. So we are diversifying our production capacity across the entire world, and Europe plays, of course, an important role.
And you will share your data so that we will have fairer health economics. I'm going to stop you there, and I'm going to hand over the mic before we get the audience in.
So a couple of things. The first one is on sort of decision-making process. We hear from Belgium the challenges as well is that 30% of the population don't feel that they have access or can afford access. In Denmark, it's universal healthcare and it costs nothing. But we have the same problem, is that many people don't go to the doctor either because it's not available or because they don't feel that, I don't know, for various reasons. And generally, it's the people who are in low-income categories or that have social challenges that are not accessing healthcare. One of the biggest challenges we have is that we have to recognize that when we're making decisions on structuring our healthcare system, that it's privileged people who are making the decisions on how the healthcare system should be run. They have to be more aware of what the actual challenges are for the people who do not have access. So this is one of the issues, and we spend a lot of time in our ministry thinking about it, that we mustn't solve our problems because we have very few problems compared to what the actual challenges that healthcare systems face or patients face trying to access healthcare. And the other one is we have to embrace technology. In Denmark, we have a sort of quid pro quo. You have access to universal healthcare, so you share your healthcare data with the system because that data is necessary to identify trends, to improve healthcare systems, and ensure that they're addressing the challenges that patients are facing. And we must be aware of being nostalgic, because AI, for example, can help us a lot. AI is much better at identifying breast cancer than people are. I think we must remember that often its decision-making is maybe your treatment process, but identification of these issues for all the patients, and it happens all the time, get misdiagnosed. We have to address that, and AI is a super efficient at addressing, especially when it comes to identifying pictures. We have to utilize that and not be nostalgic about, because that person, that individual wants to get treatment and get healthy. They don't necessarily just want to get bad news from a person.
No.
There's a big difference.
I love that. And actually, to add a little controversy and provocation, there are actually studies that show that AI is better on empathy than doctors. So we will leave that. And, the future is all AI. Do we have microphones and questions? We will take 2 questions together. Please, I see 2 hands. First come, first serve. Oh, we have many questions. This is always the case. Excellent. We start with the gentleman over there. Yes, yeah. We'll take 3 because these panelists are so concise, so we will take 3 and they will answer quickly. Please,
thank you very much.
If you could introduce yourself briefly.
Nikos Manaros, Acumen Public Affairs. It was mentioned during the debate that we need to move towards healthcare rather than sick care, right? This is also the debate of having to move more towards investment in health, and because this is not a cost. We heard from the representative from the Belgian government that we are talking about cost and how much those new drugs are going to cost the system. I would like to understand a little bit, how do we bridge those 2 discussions, right? And how, because governments do operate on annual budgets, and then from the perspective of the industry, because you brought in the element of competitiveness, what does a strategic investment actually look like, and what does stability, certainty mean for the industry in order to be able to keep providing life-saving medicines to European patients?
Thank you. That's the whole session in itself, but we will do our best to answer concisely. I think we will take one last question to do them justice. Yes, thank you. No, excuse me, I'm sorry, you were first. Sorry, the gentleman over there. Sorry, that will be in the coffee break. Apologies.
My name is Mihai Todirica.
I think you need to speak up a little bit.
Sorry, my name is Mihai Todirica. I'm from National Administration Association, Romania. My question is why we are still speaking about health systems and not about only one health system, European health system. We are still speaking about this because together we would be much more stronger and we stand much bigger pressures from the future. Also, I would like to say my personal observation. I'm also a general practitioner, family medicine in Romania. The presence of European Union in a health system, in family medicine, is almost zero. Besides European funding, we have nothing, no information about what is happening here in Brussels or other European institutions.
Excellent. Thank you very much. So I will leave it to you guys to decide, ladies and guys, to decide who wants to address which of these questions, and it will be a lightning round, because I've been told that the coffee is religious and we need to make it. So please.
I'd like to react to your question, the representative from Romania. I would dream of a European system, honestly, and it's maybe a message from an audience like Friends of Europe. I'm a kid from Maastricht and the dream of Jacques Delors. And I mean, from a payer perspective, we still have a very fragmented system today. And from an audience like you may have personally issues about the fact that having your reimbursement living in different countries is not easy. It may reflect to some people in the room. So yeah, I would dream of a healthcare system that is European and on which the rules are decided by Europe. Today, we go very practical and we try to keep the system alive. But it's an issue about professionals, how people can move from countries to countries. It's an issue about patients when they live in a country and work to another country. It's an issue. So yes, of course, we should go deeper and further in Europe about healthcare and social security.
The dream of one European healthcare system. Do we have one more comment?
Yeah, I would like to address the question in terms of how do we are bridging from sick care to healthcare. I think, of course, we need to have courage and being bold to make the right strategic investments in our health, and that will cost money at the beginning. But what is critically important is that we're moving away from that 12-month short-term cost perspective to a more mid-term to long-term perspective, because all those chronic diseases are not stopping after 1 year. They're going on and on for a long time, and the costs are coming from a mid to long-term perspective, and it's our duty to prevent those from happening. And again, I argue really very much in more accountability on the patient side with better and more reasonable incentives. And second, early intervention with highly effective innovation and medicine to bridge that challenge we're facing right now. But we need to have courage, and we need to have bold politicians to take the first step, because if we don't taking the first step now, it's getting only worse over time.
Yeah, thank you very much. Very brief.
Sorry.
Yes.
Just to thank Nikos for the question, because indeed, Alexander, the moving from sick care to healthcare is actually very, very crucial. And it's something that on a European level and national level, I think everyone would indeed try to change their perspective for the long-term causes. And then the cost effectiveness, it will be different, trying not to find a treatment, but actually to avoid being in this stage and having prevention before. And it can be promoting wellness, nutrition, education, sleep, many things that the healthcare system should adapt to. And just to connect this with the investment part, it would be indeed a need for the Parliament also to continue arguing for more investment on healthcare. Like before in the previous panel, they said, what are we doing? Are we going to have defense ministers and health ministers talking together? Actually, healthcare should be part of the defense strategy, and it's something that many MEPs in the House have been arguing for it. So not to have reduction on the investment on healthcare, but to continue to have this long-term process and prevention, also in the aspect of security and defense.
Yep. Thank you, everyone. This was another packed session, but there's coffee. You can follow up with these excellent panelists. We've heard about the really important need to move to prevention that will somehow manage cost of chronic health care and just improve quality of lives for all of us. We heard the opportunity for innovation to actually enable that, the value of data going forward. We heard about all the challenges, but we're going to leave them and say that there is an opportunity for Europe to actually manage this better going forward, even with fewer healthcare professionals. So with that, thank you very much, and coffee it is. And you will be back for another session. Thank you. All right. Welcome back, everyone. Love the chat, but I'm going to interrupt you because we have good things in store for you. Welcome back to the second half. So we spent the last hour talking about designing architecture, withstanding pressure, and Europe's healthcare systems. Now we're going to move to the next difficult question, which is we already have a lot of tools, so why aren't they working at scale? And what actually needs to change for innovation to become how healthcare systems operate, not just something they experiment with? So to help us do that, I have another fantastic set of speakers. I have Jorge Juan Fernandez Garcia, who is the Chief Innovation Officer at Hospital Clinic Barcelona. I have Elina Drakvik, who is the Senior Lead of International Programs at the Finnish Innovation Fund, Sitra. And last but not least, Ginger Smith, who's the Senior Economist in the Innovation and Competitiveness Department. God, that's a long title. At the EIB. Okay, we are going to kick it off with Jorge. So Jorge and I are also fellow European young leaders. So I've known Jorge for a long time. He's worked on the digital innovation side, but now he sits on the hospital side. So you are really the bottleneck for us innovators. And I want to ask you about, as you think about implementation from a clinical setting and really making it happen for patients in your setting, can you give me an example of where innovation has actually changed the way you deliver care? Not a fun pilot, not an interesting thing to talk about, but actually changing delivery of care?
Yes, we have thousands. So thank you for the invitation. Oh, sorry. Thank you for the invitation. And the word pilot might bring us to digital and that word with two letters that I will try to avoid pronouncing today. But I'm going to go to science today, okay? Hospital Clinic is a top tertiary hospital in Barcelona, usually top 50, top 60 in the world rankings by Newsweek. And one thing that we are proud from moving from science to clinical practice is that we have developed in the labs 2 CAR-T therapies, so 2 advanced therapies. That's normal. Everybody does that. Nothing new there. We have regulated them, and they are approved by the 2 regulatory agents in Spain and Europe. And third, we have already administered them to more than 700 patients. Okay? If you don't know what are advanced therapies and CAR-Ts, basically it's a tool in the hands of the physicians that basically allows to save the lives of usually 85% of the patients that they treat. Right? So this is quite unique, right? How do you do that? Of course, we embark in a journey that we were not ready because this is the typical journey of a pharmaceutical company, right? So you need to do a lot of things along the way. And by the way, this was never part of our strategic plan for those who favor strategic planning and all these things. So it's more about doing than just planning. Is that a good start?
It's a good start, but I want you to help us identify, let's say, 3 or so steps or things that actually made that happen. Because again, like for me, investing in this space, I can see some of the roadblocks along the way. It's about taking a sample from a patient, expanding it for a while, weeks, something like that, bringing it back to the patient. I mean, there are logistics, there's the buy-in from the healthcare staff, there's the buy-in from your hospital management that doesn't do this as a, standard modus. So there's some big things in here that you had to overcome. Do you want to speak to some of the key things that made it happen?
Sure. Let me just address 3 of them. The first, you name it, which is leadership support. Unless you have leadership support for innovation, you can forget about it. You're doing innovation theater or innovation showrooms or whatever, right? What does it mean, innovation support from the leadership team? Means that you report to the CEO. You report to the people who make the decisions, okay? You're part of the boards that make the decision. That's the first one. The second is a strong in the Japanese way of making things, a strong belief that those in the front lines are the ones who know the best on the science and how to move things forward. Okay, that's the second criteria I would suggest. And then the third is, for moving pilots to practice or science to clinical practice, you need more than just the science and the technology, right? And then for the other things, you need to support, to get the support from others. And the support from others, we are tempted in Europe to go with the cheapest, right? I don't know why, right? But I think it is a mindset to try to get the best support that you can to move things to the other side. Yeah, so I will pick these three: leadership support, trusting the right people, and the third, getting the best support from out there.
Excellent. I think lots in there. We'll get back to that. We're going to welcome Elina into the conversation. And for those who don't know Elina, she's a big champion of health data, another central component in this innovation piece. And Finland has been at the forefront of health data for a long time. So you're going to be the Denmark of the previous session. Can you help us come into your journey a little bit on, you mentioned to us yesterday, for those of us who were there, that actually you've created there's the European health data space, of course, but then you need the infrastructure and the system in place on the national level. And that, with everyone who knows anything about, everything from the individual hospital level, or rather even individual department level, to hospital, to region, to country, is scaling across different platforms and collaboration and whatnot. Do you want to give some color to a couple of the equivalent of Jorge's question, a couple of the key steps that has made that happen in Finland?
Yes, excellent question. Thank you, and an honor to be here today. Thank you for the invitation. And my name is Elina Rakvik, and I work as senior lead at Sitra. I also lead a European joint action called Tehdas 2, towards the European health data space, second joint action. And I often talk about that, but today I talk more broadly from Sitra's perspective, because Sitra is also an independent funding agency. We fund pilot projects, but also studies. And one of the studies that we just very recently funded was a proposal on the Finnish health data space. So how are we going to work together at the national level to make most out of health data? As you know, Finland is very progressed in secondary use of health data. We have had the National Act in place since 2019. And through that, we also already established FinData, an equivalent of a health data access body, which grants the permits for accessing health data for research and innovation purposes, and kind of served as a model and inspiration for creation of the European health data space. So in this national proposal, it is still at the proposal level that the ministry has now taken forward and is thinking more concrete actions. But we have three layers there. So having in place a strong data infrastructure, but also fully operational and aligning with the needs of supercomputing. In Finland, we have this Lumi supercomputer. We will also have another that is another infrastructure called Roihu that will be also serving as a very good platform for high computational high performance computing, and also provide the concrete tools for processing sensitive data. And another key layer in that regard is, of course, having this streamlined access procedure for accessing health data at the national level, but also then when we think about the integration with the EHDS, this has to be also working smoothly. There are, of course, very many practical questions and issues to tackle, but the idea is already there existing. And of course, to make that work, we have to have a coherent and active ecosystem of R&D players and actors working together, but of course, leveraging then on the funding and the data, because data is valuable only when it will be used. And a key part of this is, of course, the AI development. We see huge potential. And in Finland, we have rich national registers. We have longitudinal data. We have personal identity codes. It's possible to link the data. So we already have very strong digital infrastructures in place. It's more like taking the step forward to really making that possible. But I do want to bridge a little bit to what Jorge was saying about the applications in the hospitals and applications at the community level and the local level and at the service level, because in Finland, as I was saying, at Sitra we also fund pilot projects. We have piloted some tools for AI-assisted patient record keeping in 3 different welfare regions. And it was very well taken forward, both by the citizens or the patients, but also by the doctors. These were very short-term trials. It was only half a year pilot projects, but the learnings were that the doctors, the AI did the transcription and the doctor then checked that it was correct. The doctors were very happy about the results because they could really focus on the patient. They didn't have to write anything down at the same time because the AI was doing that. So it was estimated that they could save actually almost 40% of their work time. So the doctors were very pleased with this pilot. And also the patients, because the AI produced more understandable summaries for the patient than when they compared with the non-AI ones. So it was actually a win-win for both, for the doctors, but then also for the patients. And when we think about the problems in terms of scaling, I think we are still in the process of scaling this. These were very recently done. These have received continuation in another broader AI network that Digi Finland is now coordinating. But I think in general the problems are that we are not able to use these tools or resources across the different levels. So whatever is designed or implemented in one area, it's difficult to transfer that to another welfare region or to another hospital. And there is we still have to do more, and we have to do better.
Interesting. But you touch upon this important point of really also positioning and developing tools that actually are perceived as helping physicians rather than replacing them, and also maybe in this whole dialogue around how we educate patients, allow them to actually feel more informed about their own disease or situation. Interesting learnings there. We're gonna welcome Ginger Smith into the conversation. Now, the European Investment Bank is, of course, one of the very big funders of innovation in Europe, and you look across Europe. So we've heard throughout the day about, there was the colleague from Philips who was talking about the fact that we love to talk about the two letters you don't want to mention, but in reality, a large part of healthcare or hospitals and healthcare providers in Europe are not even digitalized, right? There's that gap between the best quartile and the least performing quartile at this point in time. So I want to ask you, Ginger, as you look across Europe, where is the biggest gap between the most and least advanced healthcare systems right now? And I'll ask a follow-up question and you'll answer them both, which is, you and I are both in investing worlds. So we look at the future, and I don't think there's a lot of investment opportunities we see today that don't touch AI in one shape or form, whether it's enabling, if it's fully AI or not. And so when you think about the innovation you're funding, are you accidentally widening the gap between the non-digitalized hospitals and the AI champions? Or how do you use this very powerful instrument of EU funding to actually raise the quality of overall healthcare in Europe?
Great. That's a great question. We do see these huge differerences. I think others have talked about where some parts of member states have this great digital infrastructure like Finland and are able to use them. And there's a risk that we have introducing AI and these digital tools that not everyone's going to get access to them because they just don't have the digital infrastructure. This I think was why it's really important for thinking about thinking about health data as sort of like something that's really important from a public infrastructure perspective. Like we build roads and trains to get goods around. Why don't we think about health data in the same way as an investment that enables innovation It enables innovation because you can use that data in developing your innovation, to measure outcomes, to actually know that you're getting what you want to get. You need that data. And then to monitor to see if things are actually going the way you had expected, and that patients can build trust that this AI or whatever the innovation is really doing what we want it to do. And so I think it is a risk that areas get stepped behind. Now, I also want to take a little bit more of an optimistic tone. I think if we can, bring digitalization, and this has been something that's being talked about for a long time. This isn't a new thing. So, and there's been success. So we have models within the member states of how to do this successfully. So let's learn from those. Because, the thing about AI and these digital tools, they can help extend, specialist services to areas that don't get them now. They're too rural, they're too remote. It doesn't make sense economically to build those services, and you can do remote monitoring of patients, even remote consultations. So there's also an opportunity to democratize access to healthcare and to better quality healthcare.
Excellent. We're the innovation Kool-Aid gang, as you noticed. So I'm going to open it to all of you, and you're soon going to be welcome. So again, get ready with your questions. We can have a little bit more time this time, I think. It depends on our panelists. So I think a classic scenario when it comes to innovation is really that we have an existing healthcare system and we add innovation on top. And it's the classic, it's manifested in the whole, when you look at how much, I love your 40% metric, Elina, but when we all look at the stats so far, it's not like technology is necessarily liberating healthcare professionals to really sit and be really present with their patients. So it tends to be stacking rather than removing and driving efficiency. So I want you all to think about, where have you seen examples of innovation done the right way? You can choose which kind of example you want. It doesn't have to be AI at all, because we're still in the beginning of that, but meaning it doesn't have to be digital. Where have you seen it done the right way, and what was structurally different? What can we learn from the successful introductions of innovation? Who wants to go first? You had an optimistic tone. I'm going to call on you, Ginger.
All right. So I guess I did want to make a comment about the innovation Kool-Aid, because I am sounding like this innovation optimist. But here's the thing. We actually know what prevention works. We're not lacking in knowledge, and we're actually not lacking innovation. We have so many innovative companies, innovative ideas in Europe, and we have those building blocks. What we really lack is the structures to help build them to scale. So this is about incentives, how you pay for this healthcare, who pays for the healthcare, who gets the benefits. And these are all really difficult political decisions. This is why we've, in some ways, it's the same problem we've had for decades. And those are the things that are really, we need to scale. And the other element is governance. And there's been a lot of developments sort of on the data governance standpoint and regulatory standpoint. And then one way governance can slow things down a little bit, but it builds trust. And it also, there's a de-risking element as an investor, because the company knows, okay, if I do this, this is the path that I'm going to get to market, and I'm going to have access, and then people are going to trust. So, I think we have strengths in Europe with our governance, and we need to keep evolving it to help these innovations scale, because we know what works. We've done it, and it's now it's bringing it to scale and bring it to patients everywhere.
Okay, thank you for that. I will ask Elina if you have an example of where you've seen it actually introduced in a way that improves efficacy, efficiency, liberates time, something, and what was the difference?
Yes, in addition to the AI pilots that Citra was funding, we also funded pilot projects in the area of digital therapeutics. We funded 6 pilot projects there, and they were also very well received by the patients, also by the healthcare professionals. There was dedicated time to introducing them for the healthcare professionals and how they can guide then, in their turn, the patients. So we definitely see there are more opportunities. We also created a learning network for all those projects that we funded, because it's not only that you are focusing on your projects. I mean, the pilots are easy in that way because you have a certain outcome that you have to reach, you have certain time frame, and you have the money to do that. The scaling part is the difficult part. But what we also try to do when we are funding the pilots is that we are trying to initially see already in the plans, how are these pilot projects building their paths forward towards scaling? How are they implementing the project so that it has opportunities to survive beyond the project lifetime? So I think this learning system is very critical, and learning, sharing these lessons learned, so learning from each other, that is crucial. So also those projects that did not receive funding, they can see what was achieved, what were the challenges, how they were dealt with. So I think we need more sharing and better coordination and raising awareness about these issues. But I do want to also come up to one challenge that we see, broader challenge, and I think Europe should really act on this. Each country is now thinking about these different kind of reimbursement systems. So it cannot be that in Europe we will then have 27 different kind of systems for reimbursement. So now I think is the time to start thinking and acting more, collaborating, and see where we can develop this European level policy to have some more common ground, because it's not driving innovation if we will have again 27 different kind of incentive structures and reimbursement structures.
Thank you. So the learning of the pilot is funded, the scaling is when the trouble happens or difficulty happens, and of course, fragmentation. Jorge, what do you say?
So my three rules would be: you need champions from the clinical side, right? That's the first thing. Second, we need to change, we need to select, let's say, it's easier to scale projects where the condition is more manageable. For example, diabetes, where basically there is one data point that makes sense, right? That physicians track, is simpler to change than other conditions where you need more data sets. Okay, it's very, very simple, right? Of course, you know, if we do it like that, we will work with the simple rather than with the important, right? That's the challenge. That's what I see. And then, of course, money. Money is super important, right? Innovation always starts with, I always make the joke, always starts with no. Somebody saying no, because it's in the word, it's innovation, right? Somebody say, no, this cannot be done. Sorry, this cannot be done. This is, you know, I'm a doctor, this cannot be done. But reality, it starts being paid by a budget that is different from the final budget that should be covering it, right? We have more and more tools for the first budgets to do innovation. In each country, we have different mechanisms, and I think we would benefit from some harmonization there, let's say. But the real challenge is, once things work, how do we move it to the regular budget, to the normal budget, to the day-to-day budgets, okay? And we don't do that because either there is no money or we don't have the means, right? And we've been talking, we were discussing before, prevention for 25 years, yes. Right? Why it has not happened anywhere in the world is because Homo sapiens are stupid. No, it's just because we don't make the changes in the incentives. Okay, I can tell hundreds of stories we were talking about. For example, value-based healthcare. I was doing a project on value-based healthcare. We were being about to pay by value, by outcomes, and not by volume. And what happened was that it broke. It was with a large corporation. I'm not going to name it. It broke not because of the large corporation top management, but it broke because sales people were not tackled, right? So basically their bonuses were paid by the number of devices that they were selling to customers, right?
Another reason to take humans out of the loop. No, I'm joking.
No, I haven't mentioned those two words, remember, I'm staying away from it. So champions, certain conditions, and then the right budget. But we need to, I'm not asking for more money, which it would be great. I'm asking for money to be paid aligned with what we're trying to achieve, okay? Because I said all the time, what we get is, you know, people, you know, I get calls from my CFO, my CEO saying, Jorge, you cannot do more telemedicine more numbers. Don't increase the numbers, right? Because we are paid by the patients, they come to the hospital, right? So we have a problem there, right? So, so we need to align that. That requires political will and lots of effort. And I fully support your reimbursement approaches. Yes, fully support.
Excellent. So, as always, it's about incentives of human behavior. We're going to leave that one for now, and we're going to bring you in. I had many other questions, but that will be for another time, because we want to get you in. And I think we're going to get some help. We're going to do a Slido poll. And we are going to ask, on a scale from 1 to 10, with 10 meaningfully integrated, how extensively, excuse me, of course, I've been told you're supposed to scan, but you know that yourselves, I see that. How extensively have health systems incorporated digital, mainly, I guess, or AI tools at the design level, as opposed to just using them for individual care decisions? So you're going to offer us your input, and then we're going to hear from the panel. So I'll give you a minute. Do you see? Yeah.
The machine doesn't work beyond 5 or what?
Yeah. let's say that. But I actually think the way to read it is that 6 is the third best option. Yes. Yes. Okay. No. Okay. So maybe some people are still voting, but I think we see the general pattern that it's at best lukewarm. I think that's what we'll say. At best semi-extensively. Do you want to comment? Is this surprising to you? Is it exactly what you expected? Why isn't it better? Because again, let's just leave AI out of the equation. That's a new phenomenon. But the concept of data in healthcare, whether we call it data or big data or something else, it's been there for all of our lifetimes. So why aren't we doing better? Is it surprising?
I am reading this, that the second position is the scores with 6, well, the third now, okay?
Yeah.
It's surprising because I think in general, when I talk to colleagues around Europe, we are still testing things, we're learning about things, so we are still not thinking systemically, right? So at all, right? Maybe we sell it differently. There's a big difference between what you read on LinkedIn and in conferences and what happens in the real world for people who don't go into the real world. But it is like that, I would say. No, 1 or 2 would be to me the surprise. 0 if it's a number there.
Okay, well, I will say that the top 3 is between 2 to 4. So do you want to comment, Ginger?
Yeah, actually, I would build upon that. I kind of feel like this could be a bit high in terms of what we're seeing in our portfolio is that the innovations are coming in, I guess, areas where there's already a market for it. I think we know where those are. Those are diagnostics, imaging, sort of easing administrative burden. But they're in this hybrid environment because they know that the place to go and where a big market would be is it's this more transformative solution. So they're having to sort of navigate that they need to sort of be able to make money and be able to sort of have a market initially, but then building products that have the potential to do things more transformatively and more systemically, should that system sort of evolve with the incentives that they can actually build that market. So it's a challenging environment because there's a lot of uncertainty and exactly where these business models are going. So that's what we're seeing.
Chicken and the egg. If this is the state of play, it's hard to be a truly disruptive digital company. Absolutely. What do you say?
Yeah, just very shortly from my part, I think this leaves very much room for improvement. So I think we really need to focus on being more innovative at different levels. And this doesn't go only to the kind of the organizational cultures or how are we fostering innovation, but this is also a more broader societal question. How do we foster and value science and research? And of course, there are different levels, kind of trust in society and also towards science and research. I come from from Finland, and in Nordic countries, it has been traditionally very high trust towards science and research. But we know that this is not in all the different countries and across Europe. So I think we need to keep this in mind and also talk more about promoting science and research in general to generate trust.
Okay. Two, I think the only way is up. So let's conclude that there's a huge opportunity out there. I want to open the floor to questions, and we'll do the same. We have a little bit more time now, so we're going to take at least 3 questions. We have one first here from the lady over here, and then the gentleman over there. I think we can squeeze one last one in because this panel is so concise. Welcome. If you don't mind introducing yourself.
Annika Eberstein from Philips. I have a question in view of the coming revision of the Public Procurement Directive. So what's the role of procurement rules here in getting innovation faster into health systems in the future?
Thank you. So procurement and how to handle that. There was this gentleman over there, and then the lady over there. Yep.
Thank you, and for all the panelists as well. I'm Yusuf from Bristol Myers Squibb, and I will take off my pharma hat for a second and put on my ex-scientist PhD student hat, and specifically for Jorge, because I find the CAR-T development part very, very interesting. And just maybe wanting to ask, how is it that then you saw a bit of harmonization already internally within the hospital, the people that are doing the fundamental research, and then bridging that with people that are doing translational research, and then further to clinical research, to end up actually having a project? Because we see a lot of fragmentation already within one research group saying, I'm fundamental, I'm the start, to having that go a bit more translational, and having sometimes doctors and MDs not really willing to collaborate with more early stage. So how did that happen, and how did you kind of bridge that in order to end up having really a product that you can help treat the patients with? Thank you.
So I'm going to say interdisciplinary because I want to add, I'm going to be on your side, and add to the question, which is, of course, in an era of computational. I was on a panel a couple of years ago, and someone said, so many of us went into biology because we were not good at maths, but, that show is over. So the interdisciplinary side of digital innovation in healthcare, but definitely from the preclinical to the clinical. And then there was the lady over there. Yes.
Thank you. I want to bring in a little critical note about innovation.
Please introduce yourself.
Yeah, sorry. Lydie Meeheus from Anti-Cancer Fund. Because I want to point out the difference between novelties and innovation, because I think biotech and everything that comes out of the research are very interesting novelties. But what I've learned is that we only can talk about innovation if it really serves society, if it's a novelty turned into value for patients. And that is something I'm missing here, because it seems like everything that comes out of biotech and which is high tech will serve the patients, but we need evidence for that. And we know today it's not the case. Especially if you say when it's proven it works, it has to be clinical adopted. I tend to not agree. When it proves value for patients and when it's better than compared to the standard of care, then it should be brought into clinical adoption. And that's the step I kind of miss here in the discussion.
Okay, thank you. So procurement, interdisciplinary, and honestly delivering value as opposed to just new bells and whistles. Who wants to go?
Start with procurement. Thank you for bringing that up. I actually wrote the word procurement as we were talking, that I wanted to talk about it because, yes, we've been sort of talking about reimbursement and healthcare financing, but when we're talking about digital tools, this is usually software that's going through a procurement regime. And if we're just the lowest cost procurement, we're not thinking about long-term usability, interoperability, and these sort of systemic factors. So I think that's a great point, reforming procurement rules to really go at the value that's being created.
I can pick up on this value for the patients and what is the value of the innovation. At Citra, we also talk about societal innovation, and the societal innovation means that it has real benefits, beyond just one organization or one party or one target group, but really delivering value and results for those who need it. And I think in all these examples that I was telling about, the patients are part of the giving the feedback about the pilot projects. So they have been very positive. And of course, they have also seen the difference when it comes to their disease outcomes or their treatment plans and how things have improved in their daily lives. But I think you're absolutely right that we don't often talk so much about the value of patients, and we talk about patient-centered care, but then in practice, in healthcare, people are busy, healthcare professionals are busy, the patient is there, but it's more like not doing with them, but for them, seeing as a target instead of doing it as a collaborative journey in a way.
Yep. Thank you. Jorge?
So I agree that, for example, hospitals, we don't talk about patient-centric care. That's what we do, right? The industry talks about that, and I fully support your view here, right? So procurement, to me, equals nightmare, okay? It is super complicated. We've been learning about regulations and procurement and 3 offers that we need. It's just so complicated. I go back to my previous comment from yesterday, speed is of the essence, right? I'm not saying we should do it the Chinese or the American way, but speed is of the essence. That's number one. To the gentleman here, how do we do it? Because clinicians are the best researchers, right? Clinicians, if they want to get ahead in my organization, they need to do research, they need to do teaching. And if they don't do these 2 things, they don't get paid more and they cannot be promoted, okay? I'm working now also with innovation. So if they don't innovate, they don't get paid more, okay? But it is part of it, let's say, right? So we have a bunch of basic researchers, but 60% of our researchers are clinicians, right? So clinicians seeing patients and also doing research, okay? And to me, the question of all this is that unless we take action into this, there is a big cost associated with this. And then people will say, Europe will not have drugs, access to drugs, and then we'll have shortages of doctors and nurses, these things, okay? To me, the real problem we're facing with healthcare, on top of inequality, is that we are breaking seriously the fiscal consent, which means that our patients or citizens, they pay for health services that they are not getting real access to these, right? They're getting 1 year, 18 months to be seen by doctors and nurses, right? And unless we do that, there will be a point where people will say, why should I pay taxes? You know, if my kids cannot go to the right universities are private, how, you know, if my parents, you know, I need to send them to a private long-term care facility because there is no public, well done. If whenever I go to the public health system, you know, they tell me, I'll see you in 18 months, right? And that's why, unless we solve this, our welfare systems and our social contracts will be broken, and they will be like the others and will be last. Okay, so to me, this is critical.
Thank you so much. So I think to conclude this session, somehow we keep on coming back to incentives. If the incentive is to really improve outcomes for patients, I actually think it's a consensus that innovation has a role to play. But somehow it gets lost along the way because the incentives to encourage innovation are not fully aligned from the beginning till the end. I think that's one key conclusion of how we need to change this going forward. I also think this thing about the value for patients and the social contract. I mean, I hear you. I think it's a really, really fair challenge to use the Kool-Aid of innovation. But I would still say that in a global perspective, Europe is still really well placed to think about value creation for patients because of our single payer systems and so on. So I think that's something that Europe should keep on pushing at the center of it. What is actually the value of what we're creating? Thank you very much. We will now thank our panelists. Thank you. And with that, I will also say thank you and transition back to Valbona. Welcome.
Well, thank you very much, Nina, for that great panel. Should we invite this? I would like to invite the speakers here. Please. So here we are to continue the conversation on what to do on reimagining Europe's health systems. And across the panels this morning, prevention and preparedness were keywords, so we'll come back and focus more specifically. I like the title of the panel, and I'd like to thank my colleagues here at Friends of Europe when they say, put the title of the panel, Prevention, Preparedness, Reducing Risks Before Systems Break. So I think we need to add that sense of urgency that we were also discussing last night, and the sense of speed of reforms. So we have seen, it was discussed more time this morning, that chronic diseases are a major driver of health system strain. And a critical vulnerability during crises. So prevention, we have discussed, remains underused as a policy lever, often treated as a communication exercise rather than structural function of resilient health systems. So we know that across the EU, we're still organized mainly around diagnosing and treating illnesses once they have developed, rather than around preventing disease through screening, risk management, community-based care, and population health approaches. So to discuss more on this topic, we have here a brilliant panel. Jennifer Murnane O'Connor, the Irish Minister of State for Public Health, Well-being, and the National Drugs Strategy. Thank you for being here with us today. Sandra Gallina, Director General at the European Commission for Health and Food Safety. Thank you, Sandra. Casper Ernest, Director General of the European Healthcare Distribution Association. Delphine Henin, founder of Kick Cancer. And Stefan Foxström, Senior Vice President of Europe for Europe and Canada at AstraZeneca. Thank you to everyone. So I'd like to start with Minister O'Connor. So, we were lucky last night. We had a dinner conversation, so some of the main, I think, issues that you will raise today, we already discussed last night. We know that Ireland has adopted a new 5-year public health program, which aims to improve health outcomes and strengthen the health system. Though I like that in your title, you have the well-being too. So you're not just looking at strictly, the health, because when we think about health, we think about diseases. So what is the focus of prevention and preparedness, and what is Ireland doing? What are you doing? What can you share with us today?
First of all, thank you very much. I'm delighted to be here, and to all the panelists here. Yeah, I'm Minister Jennifer Murnane O'Connor. I'm the Irish Minister of State for Public Health, Wellbeing and the Drug Strategy. So we were very lucky. Well, recently, within my own remit and working with the other ministers, we adopted a new 5-year, what's called a health prevention plan. It's the first time we've done this now. And there was 6 key pillars in it. Well, aims, I would say, that we're looking at. So, of course, first of all would have to be, of course, the new AI, digital. That's the way forward. That's something we really have to address. Forward planning. Then we have climate change, because with that too, we see all changes in that too. That was the other thing. Then we have our strategies, how within our own area, how we prevent these strategies. So we are now looking at community-based health cares as primary care units. What we would say is our sláinte care, which is very much part of being part of the community and how we prevent in the community and to keep people out of hospitals. They're the key pillars in our new plan, and hopefully now, it's a 5-year one, but we have already started working on a lot of them, and going forward now, that's what we will be doing.
Great. Can I ask you a question? So how much money you're putting towards that? No. Because, in Europe, it goes between 1% and 8%, depending. It's very diverse, the funding that goes into prevention.
Yeah, at the moment, the prevention, we've only started this. So while we have a small budget, I believe we will grow in this. So at the moment, the budget on these key pillars, we have, every budget will be slightly different. So an overall figure I couldn't give you, but it is a priority. And I do believe this, and I listened to other speakers there. The only way we can work on this plan is through prevention, communication and awareness. So every pillar will have its own certain areas of funding, like through the data. So how we work on our data for our hospitals, and how we, like recently, and I'm sure you have this, we have what's called now virtual wards. So these virtual wards in our hospitals, I know there's one in my own local hospital, which is a virtual ward, which is people that have been in hospitals, they come home, then the hospital are working with them at home, and there's a new kind of a data system in this. So there's a lot of good work being done, but they are going to be looked at individually and how we fund them individually. But I can assure you, within my own remit, we're always looking for extra funding. I can assure you of that.
No, that's a great point. And just to put that into the bigger context, I mean, we know that in Europe, Europe does not lack evidence when it comes to prevention, how important that is for the healthcare systems. Though broadly, it's only, on average, it's only 5 to 6% of the healthcare budget, which is 5% on average of the GDP. So only 5% of that 5% actually goes into prevention. So that is also one of the main challenges that we have seen.
And that's why with this plan, we know that now, look at the challenges is for everywhere is people are living longer. And while that is really positive, what we have to do now is to work with this and work within our own health system. Our HSE would be our health system, is to see what we can do to prevent. Prevention is the way forward. It brings us challenges, but it's actually working on that. And that's why we started with this 5-year program going forward.
Thank you very much, Minister. One quick point to add to that. So, how will you use the Irish presidency to make of the EU to make progress on those issues? We were discussing this morning in the panel when we talk about the broader resilience. Will you bring defense minister together with finance ministers and health ministers to really talk about health as one of the structural pillars of European resilience, European competitiveness, European security?
Yeah, absolutely. And this is part of it. And I will say within our own system, within our own budgets, we work with all different departments, whether it's to housing, which is another part too, whether it's to housing, whether it's to education, whether it's to finance and other areas. So that is a part of it. Everybody has to collaborate. And that is the way forward, because you know yourself, everyone's going in for their budget. Everyone is fighting for their own budget. But collaboration here is going to be so important. And that is part of our EU presidency. It's everybody working together, all the different areas. There will be conferences and there will be programs on whether it's housing, whether it's finance, whether it's healthcare. So it is important, but it has to be joined up thinking. And I think our 27 members of the EU too, we all need to collaborate. I mean, I know I was going to be asked a question on rare diseases, on funding and things on that. So like it is important that for the likes of, which are so important, our rare diseases, that we collaborate with other countries and look at a funding stream. How do we work on this? Because it's with collaboration is the only way we can deliver. And it's like what your previous speaker said, these are human beings. We are working with health, well, particularly in our own health area, people who are very vulnerable, people who are sick, families are affected, whether it can be your mental health, whether it can be finance, that you can't maybe afford to get a service that you need. We always have to remember at the end of the day, we are talking about human beings that are very vulnerable, that need services and need medication.
Thank you. Thank you, Minister. Casper, when we talk about preparedness, prevention, where do you see the mismatch between policies, beautiful strategies, between our objectives that we have, and then implementation, and where are the market incentives to make it work?
Yeah. Well, currently, unfortunately, the market incentives are somewhat lacking in many respects. I think...
And why is that an issue?
That's an issue because we can have all the good ideas. I can give you an example. Today, my members deliver more than 19 billion packs of medicines to more than 200,000 pharmacies and hospitals. Every day, more than 70 million packs, right? We're out there on the streets, actually. But at the same time, all of us goes to the doctor to get a blood sample taken. And that has a separate distribution system where all the trucks are coming to collect the blood samples. Why aren't we using the pharmacies to do blood samples, right? It's just a small example. And today there is, I would say, we've moved from, I will challenge first. I'm not sure it's a question of lack of money in health. Not entirely sure. If we would actually sit down today and look at the challenges we have ahead of us, if we look at the demographics, if we look at the number of young health professionals, right, the numbers just don't add up if we continue doing how we've done so far. So the reason why we also thought this was a really interesting topic is because we've been talking about reforms for years and years. But reforms today, if I may be a bit provocative, consists of sitting down with an Excel sheet and seeing how can we fiddle around with the numbers so that we get from this ice flake to the next one, right? The ship is kind of sinking to some extent. I'm not negative about it, because I actually fundamentally believe that if we are able to, and now we call it reimagine because reform doesn't cut it anymore, if we are actually able to reimagine how we do things in our health system, we are able to do it. With the technology we have, with the infrastructure we have, we can actually make a true change. Where we see a mismatch is very much we have all the good pilots, we have the examples of the diabetes care, but we end up, we have shared visions, right? But there's somewhere between the vision and the micro level that it just doesn't come through. So one thing we're missing is definitely leadership, but also it's not just collaboration, it's actually being able to put through a strategy that is actionable and that trickles down. There we're not good enough. No one is currently sitting down and saying, okay, these are the things we have, how do we better utilize them? How do we rearrange things? So it's a lot of things, sorry for being a bit long, but this is where we have to start changing. And if we look, for example, at COVID, suddenly everyone realized, oops, we need to get medicines from A to B, right? It's not as simple as we think. In a lot of member states, the military was asked to do it. After a week, they called us and said, oh, can you help? Yes, of course we can help. But in that instance, a lot of member states said, yeah, God, we have this infrastructure, we have to invest. That investment is already going away, right? Already. Priorities are changing. We saw pharmacists who were able to do vaccines, COVID vaccines in many countries. Some countries, it's now finally moving with pharmacy services, right? Where you actually put money behind it. So you say, if you do that service in Ireland, you've done a lot. Yeah. You're actually remunerated, because people also tend to think that you go into a pharmacy and somehow that's just there and it's for free, right? But the pharmacist who is only being paid to actually dispense a pack of medicine does not have time or does not have the capability to hire more people if you want to have different kind of advice. And so we just see, and now we see countries that are rolling back. Pharmacies can no longer do vaccines, which they did during COVID. I'm flabbergasted, to be honest.
Yeah, but let me go back. I mean, just the examples that you're explaining, with the pharmacies and all that. I don't think, what you're explaining has to do with reimagining. It has to do with efficiency. So why are we missing that?
Because we're not...
The trucks and the different, distribution systems and all that. It's pure logistics efficiency.
I can give you an example from our sector alone. When we speak about remuneration, every time we do remuneration reforms, right? We sit down with the Excel sheet, and our remuneration is typically regressive. So for the lowest price medicines, we get a fixed fee, then we get a percentage, and then we have a ceiling for the highest price, right? That's what we get for delivering a pack. When we talk about reform, we sit down with the Excel sheet, and on our side, we try to say, okay, how could we increase the margin a little bit on that spectrum? How could we increase the minimum price down there? And the ministry will see, okay, but then how can we at the same time move the price level a little bit? And so in the end of the day, it's a dog and cat fight about the money, right? That's not a reform.
So it is about money.
Yeah, but it's not a reform. It's not a reform. It's a reshuffling of money. And no one is sitting down and say, okay, if we took and we shut down that part, and we took that money and spent it here, we could actually save so and so much. That is reimagining, that is reforming, and that's what we're not doing today for many different reasons. I can just say from an industry perspective out there on the floor, we are not doing it. And every time we start talking about it, it seems hard. And I think we've come to a pressure point where as I said, we're jumping from ice flake to ice flake, and it's very hard to put on the long lights in that instance. So it really has to be a collective decision, and otherwise we're going to get there by the failure of delivering, right? So that's where we're lacking.
We saw that during the pandemic, the COVID-19 pandemic. We saw the fragility of the supply chains, the distribution, and all that. So we were, in a crisis. So what did we learn? And I want to ask to you from the industry perspective, because we're talking about de-risking, we're talking about supply chains, we're talking about reshoring, nearshoring, friendshoring, whatever you want to call that. But what is actually happening
What happened in practice in COVID was that all silos were broken down. Sandra, you were doing things you would have never done in the past in the Commission very well.
That you say.
Fair enough. At least the joint procurement and so on and so forth was not the common practice before. In Ireland, you broke down silos immediately. Everything was possible because we were in a crisis. So we broke down the silos. We are currently rebuilding the silos. I can't tell you why we are, but we are currently rebuilding the silos. And that was what COVID did. It broke down all rules, so to say, in a positive way. And it broke down the silos, and we were able to do things that we have been discussing and that we've known for 20 years we should be doing. And suddenly we could do it. And that's where I'm the only negative point is that we're even going a bit back in some countries. But I will mention again, I'm positive because in many countries that has sustained, and we are, for example, seeing new service models in pharmacies, as I mentioned, also for my own members. So we see some changes were persistent, but not enough. And it would be nice to have that sort of thinking coming back a bit and that urgency coming back. And that's why, you say never waste a good crisis. And I think we're just not fully aware of the crisis we're in currently with health.
Well, Sandra, then I'll go to you. Are we fully aware of the crisis that we're in?
I suspect so.
A microphone, please.
Yeah, I suspect so. My voice carries, so I don't think it's it's problem. I suspect so. I suspect also that there are layers and layers of crises, and there's this fashionable word, polycrisis, whatever it means. I think that the first concern at the moment is the Russian war of aggression on the Ukraine, for a very simple reason that is going to be a very big moment of stress economically for Europe. We have now perhaps an opportunity to start the enlargement negotiations. My DG is very busy with enlargement negotiations with many countries. So I would say we are aware, and even at the level of, I would say, the public about crisis. The problem is the multiple priorities that develop, and you have priorities that are, I would say, in a pull factor. You may have more attirance for certain types of investment that give you a quick return, or at least will be more profitable, and then you have the others lagging behind. So for me, it's clear we have learned our lesson. We also have painfully learned how easy it was to break the systems. I know that in some countries, including in Italy, we are trying to alleviate the strains on the system by creating more actors. For instance, the pharmacies is a big debate, including in Italy, about getting them to be poles of services, and not because they are very capillary. In every small village you have a pharmacy. They have a credibility also element. So I will not go there because it's quite contentious, because then there was the big discussion on who signs at the end of the day the blood test results. And in some respects there's very good practices, and in some respects we discovered that this was not done the way it should be done. So it's a big debate for those who are Italian in this room. We know that pharmacies may become poles of services. But I would suggest also that we stop thinking of health as only an appendage to the economic world. We have, unfortunately, this expansion of crisis that has made health dependent also on different landscapes. We may be thinking of security landscapes. So a country like Ireland has a different profile from Poland. I've just had a meeting with the Poles, and for them the war is coming. So there's also climate that you mentioned that is getting very worried all the countries, including for communicable diseases through pests. Beautiful Sweden has become the kingdom of all the ticks during summer, so you know your kids would not be very well advised to go out for a stroll in the beautiful gardens of your grandma. So all these different tensions, then in the end, perhaps I would agree, in the past, we used to take the ballpark figure of the money and that would be reconverted into what you want to do. But this is no longer sufficient. Why? Because we have a demographic that is quite complex, very old. 85% of the care that you need, you get it in your last 15 years of age. So that's when you get, or when you're young, you're not a big burden for the healthcare system, apart from a few very sorry exceptions. So the systems are at a breaking point for different reasons, not just because we did not learn the lessons. If I were to be true, in addition to these different landscapes, the process of keeping the ballpark figure still very much in sight is there because of tensions with other portfolios, including defense. But I would say that people are trying to, like the minister, and I'm very grateful that she was invited because Ireland is really trying to be a beacon on this element of prevention. You know, you need to move, this is the paradigm shift, you need to move the very costly burden of care in hospitals. It's very costly. And, you know, in some countries, including the one I know best, this care includes long-term care for the elderly, which is a conflagration of things which is totally negative. Keeping an elderly person in a hospital bed just because there's nobody around in summer is not a good recipe, neither for the health of the person, which is very important, but also for the budget. So if you look at that burden, which is massive, is being moved out into prevention, but prevention requires communities. And this is where I think some countries have a better chance, because the communities have somewhat a sort of elevated educational standard. It's very easy to promote prevention in some countries. I always say that, for instance, in Sweden, you may die before you get an antibiotic, but the person in question would never complain because they know why they are being so strict on antibiotics. This is for the better functioning of the whole of the antibiotics on those who need it. It's much more difficult in other countries where if you go to a doctor, you may be faced with the fact that the person does not feel even treated, even though for a virus you should never prescribe an antibiotic, but they get this prescription so that they go away. Let me be a bit clearer with you. This burden shift, so no more getting into the hospital because that is already too late. Will it prevent systems from breaking? Alone, no. We need to do much more than just simple prevention. It's a whole health ecosystem that needs to change. Never forget that I also have the other part of health, which is which belongs to the One Health. So if we start from the environment, everything that is on the surface is mine. Unfortunately, plants, animals, and then humans. And sometimes I have the feeling that this One Health element is forgotten. So prevention starts even before the human. And this is where things become much more complicated because there is in the whole of agricultural activities, there is a revenue, farmers cannot be, the burden cannot stop with the farmers, if I want to be clear. So the way that we massage this burden around, and I agree that many a time the reforms were just keeping the figure healthily there and then redistributing the burden. This time, I think that for crisis, the cross-border healthcare regulation has created a different landscape. For, I would say, non-communicable diseases, we are going into determinants of health, including tobacco. And I would say for communicable diseases, we are trying our utmost, including, I would say, with this fascination we have with vaccination, where we want to do things that scientifically there is no more border between the communicable disease that turns into a cancer that is a non-communicable one. I'm referring to HPV and hepatitis. So let me say to you, for those who, and I see a very high-level audience here, for those who work in the field, a lot has changed and nothing is taken for granted. So I would question the word reform as what we do, but we're definitely trying to change
to the complexities of the exactly to all the layers that you rightly pointed out. So I think we'll come back to that conversation. I'd like to go to Delphine. You are the founder of Kick Cancer, as I introduced you, and so you have been focusing on pediatric cancer, an industry that it's been an area that the industry has not really stepped up in recent years. And so what role should Europe play into driving the innovation also for the kids that need this service?
Yes, there's a bit of irony in inviting someone from the pediatric cancer community in a discussion on prevention, because if one disease is not preventable, it is pediatric cancer. And early diagnosis is also not relevant. So it's a very different, complex, different set of issues that we're dealing with. And indeed, as you underline, one of the main troubles that we have is the pediatric oncology community has been very resilient since the years 80s to collaborate at a European level to improve treatments for children with cancer. And so the overall cure rate for children has drastically improved and is quite favorable in comparison with adults. And so in average in Europe, we reach 80% of cure rate, but we see huge discrepancies between European countries. And so in the eastern part of Europe, we might see 20% less cure rate than in the western, richer part of Europe. And what is very striking today is that although we have reached the maximum of what we can achieve with old drugs, we're still stalling in terms of cure rates. And some children really need better drugs to be cured. And those who are cured today also need better drugs to actually be safe from the long-term side effect caused by the toxic treatments that we administer to children today. Unfortunately, we don't see the industry stepping into pediatric cancer, and I think that we have to be realistic with the fact that the number of patients that can be treated with a new drug will never make it profitable for industry to actually start investing. And so we're really in a situation of market failure. So I think that in a situation of market failure, that's really where we need Europe and we need policies, and we can't rely on the market to solve things. And so we need several things. First of all, developing drug is costly, so we need investment from public authorities. So the European budget remains key to make sure that we fund research in the rare pediatric disease areas, because children with cancer is one thing, but every child with a rare disease is dealing with the same problem. And there is now, for instance, a drug that is about to come on the market developed specifically for children with a brain tumor. And it's great news. It's one of the first in quite some time that is developed specifically for that drug. But what we see is the market failure goes all the way to access, because that drug is going to be registered in the biggest European countries with a problem in the smaller ones. So in Belgium, for instance, where I'm from, we're struggling to make sure that the drug will be available for the Belgian patients, because we talk about 8 to 10 patients a year on a rolling basis that can be on the treatment. And so there's no way you can make money with that. So we need European investments to make sure that the drugs are being developed, that there is an interest. Maybe we need dedicated incentives, or we need a completely public development pathway. It's really a political choice that needs to be made. But I think that as long as we keep the industry into the loop, there is also a risk that the price tag ends up being so high that access will remain a problem in the end anyway. So I think that it's really a call for a European moment of clarity where we make choices. Shall we support children with rare diseases with a clear need for either investment plan, incentives, and then also the courage to organize healthcare systems in a way that makes it possible to develop drugs in a specialized way.
But you mentioned something about the differences that exist in European countries. So it doesn't make much sense in the sense that we're talking about a single market. So why does it have to why it has different times, or why some drugs, in this case for pediatric cancer, are adopted quicker in some countries rather than the others?
Well,
from the policy perspective, since we have a lot of policymakers here, what needs to change?
The European HTA is hopefully making a huge difference, but the drug I was mentioning was being evaluated by the European HTA reform, which are definitely welcome. I think that ensuring that quality of life is assessed at the same time as security and efficiency by EMA is really the dual view that we need to set up to make sure that we create value for patients with a drug that we put on the market. Unfortunately, the payment step remains a national one. And that's where there are inequalities. Some inequalities are caused by the size of the market. Some of them are caused by the complexity of the regulatory landscape in certain countries. And so these are truly national policy questions. And so I think it's difficult to solve them completely at the European level. But what should be solved at the European level is we see that we need infrastructure to develop drugs efficiently in those disease areas that are not profitable. And so we need to make sure that we identify the best research centers, that we support those to get the drug developed faster, more efficiently, maybe only by academia, but also that we make sure that patients can travel. And so we come back to the topic that you mentioned of cross-border care. Cross-border care is conceived today as something that you should access for primary care. But clinical trials in life-threatening rare diseases is part of standard of care. Patients should have access to clinical trials, and they need it because it gives them hope to cling on to, on the one hand, but it also builds the pipeline for patients for those clinical trials. I mean, in pediatric oncology, when you set up a trial, a phase 1 or a phase 2, you talk about 50 to 100 patient stops. And so if you don't have cross-border care, if you don't...
You have to have, exactly.
You need it to recruit the patients.
Exactly. Well, thank you very much. So now I'd like to go to Stefan, because always, industry, it's a very important part of this conversation. And usually, when we think about industry, AstraZeneca and others, so we do not think so much about, prevention. We mainly think about medicines to cure us. So where do you see the role of medicines actually in prevention phase in the debate that we have nowadays in Europe?
Yeah, thank you. And I think it's been a very good day today, and I think we have concluded a lot of things during the course of the day, but also here in this panel. We talked about the aging population and was mentioned here today, which is a big burden for us because we consume more, of course, healthcare in our last years of life, but also the burden of chronic disease, the NCDs. We know today 150 million people approximately live with one chronic disease. Many have two. I mean, we're 450 million approximately. So, I mean, it's a big proportion. The other thing is we talked about this morning, we heard from the minister in Greece, the shortage of work for us, HCPs, so, doctors and nurses are reaching pension age, and it starts to be a bit critical. So what is left that we can focus on? Of course, there needs to be, when it comes to prevention, we need to identify patients. And I think, Sandra, you didn't talk about it, but from DJ Santé, we talk about the cardiovascular plan. We also have, since before, the Beating Cancer Plan, which is about identifying these, diseases very early. And typically, identify blood pressure very early, treat it is relatively simple if you start early. Maybe you can even avoid, and you can exercise, but identifying those patients, make sure, we do the right thing from the beginning. Also, cholesterol is very easy things, but these are just some of the things. So yes, medicines also comes into to play here. And if you look back in the last 30 years, I mean, if you look at the life expectancy improvement we've done, approximately 8 years, of that, it's been a lot of initiatives, but medicines have played a big role in that. There's approximately 70% of that increase in life expectancies due to that. The other thing is, of course, better procedures and care that you can provide as well. So everything plays a role in an ecosystem. My worry is we start identifying new patients and we're not having the right medicines to treat them with. And the reason why I'm worried is you probably know that a lot of the medicines that are discovered today are not coming to Europe. And actually, it's the latest data from IQVIA, which is our independent provider of this data, showing that 47% of medicines that are introduced in the world are not coming to Europe. Why isn't 47% coming to Europe? I mean, 15 years ago, that number was 14%.
But what is the reason for that?
Yeah, conditions aren't right. I mean, take one thing. Those who make it and being registered in Europe, it takes 600 days. And it was just published, this weight indicator. It takes 600 days for a medicine from approval in EU to get to the market and get priced and go to patients. 600 days in average. It's a very long time.
This is, yeah.
Yes.
And it costs lives.
Yes. And there are also geopolitical pressure at the moment. And the US administration is putting pressure on Europe. And one way they put pressure on Europe is you are not contributing to balancing the funding for new medicines, R&D, because you demanding the lowest prices in the world. Over here in Europe, and you have the same, reasonably the same GDP as US, many countries at least in EU. So we should need to rebalance this one. And what they basically say, and US is the big country with around 53% of global revenues are coming from the US and 20% from Europe, and they say we want the European prices. So that has escalated this downgoing trend of medicines being introduced in Europe. And we now see a 35% decrease in medicines being introduced in Europe since that came into place 10 months ago. So if you go back 10 months before to 10 months after he implemented, the US government introduced this, we see an accelerated trend going down with 35%. So I think we need to start looking at and valuing new innovation of medicines differently and see them as an integrated part in the prevention and addressing chronic disease. So that's something that needs to increase the competitiveness of Europe, because it's so tight to the health and well-being of people living in EU, and also a productive workforce.
Absolutely. It was mentioned previously also during the panel when we talked that there is this, innovation excellence in Europe, but what's missing is the scaling up to be competitive. So my question, and that'll be for you, but also for Sandra, can we afford it to be so fragmented? First inside Europe, but also in terms of transatlantic relations. So we bring it to the broader geopolitical perspective.
Well, definitely you're asking to someone who is dressed in blue with yellow stars. I don't like fragmentation in Europe. So the answer is very simple. No, we can't afford it. And we start singing the hymn of the Ode à la Joie. Now, going beyond the anecdotal, I would like to say a few things. Can we afford to be fragmented? No, but can we have a stimulus to go beyond what we have today? Frankly, difficult to see. So for health, we don't have really the same competences that I had in 22 years of DG Trade. So at the end of the day, I am making good of what we have. The member states are very, I would say, responding quite well to the idea of the health union. So there isn't much of a dispute about competencies at the moment. Do we need a new treaty? No. We can do good things without a good, and I take the risk of saying this. When you talk, however, about all these figures, I want to put a few figures right, because I'm a numbers person. 47%, not all of these are totally innovative medicines. We don't need 50 statins. We maybe have created in the past with a system of incentives many me too, I would say, medicines. In the current reform, we are trying to solve the issue of the rare diseases. So, I know the pain we have met in the past, and we have ideas also about the financing that should go behind this. It's not just that we meet today. So for the rare diseases in the pharma reform, we have tried to incentivize unmet medical needs where orphans and rare diseases are privileged, and we hope that this will be seized by companies. There is also an issue of having the authorization not only in limited time, that you will see also in the reform and in the Critical Medicines Act, where we are having, I would say, slashing the times of authorizations. But allow me to clarify that we were slow, not because we were slow as Europe, but because we had the stop of the clock for the industry that was delivering insufficient files, and then we would wait and we would stop. So these 680 days that have been blasting my life, when you study it, this is over now. We will no longer have this stop of the clock, and you will see that industry will deliver the files quickly, otherwise no authorization, which is what the Americans do. So a bit taking a leaf out of the American system will do us good. I also think that we need to really be very careful on this issue of pricing and how we want to go about pricing. So definitely innovation needs to be rewarded. You're finding somebody who is fighting also during the negotiations of the pandemic agreement to defend intellectual property. Europe has made no mistake that we will defend intellectual property. On the other hand, the price needs to be the right one, meaning that if the member states are negotiating and are offering, because let me say also the 150, which is 1/3 of our population that have chronic diseases, is a very good market. Sorry to be crude, I don't want to be crude, but it's a good market. So any member state, big or small, is putting on in front of the industry a system of public health which has a lot to offer, including the European health data space, because this is revolutionary. You will have quite a lot of data for the secondary thing. So if we want to make the equation correct, it's not just what we did in the reform of the pharma or in the Critical Medicines Act. There is also a retour d'ascenseur with the data, which is the fuel of the future. And the member states have to square their budgets. So they negotiate prices, putting big numbers of public health. So I would not go to the US, because I have just read, and I will not quote figures, about the state of real health in the US. It's very poor. So let me say to you, I continue to fight for a Europe that is somewhat, I would say, avoiding inequity or promoting equality. I don't know what you want to choose, but it's more or less boiling down to the fact that somebody with a rare disease in a small country should not be deprived of a medicine that exists in Europe, which is paradoxical. So we are fighting for that. We hope that the reform will address that issue, because we dealt with it. And I am sure that just like the good cooperation we had during the COVID with industry, is really fundamental. I'm sure that industry will seize the opportunities in Europe of the EHDS, because I have companies in America salivating for the data that we have here. You are sitting on a big pond of gold. Yeah. So and also I think industry will see the opportunities of the Biotech Act, where we are extending the SPCs with a lot of opprobrium from everybody, because everybody, but you know, innovation needs also to be rewarded. It then can be shared with others, and AstraZeneca has always been a company that tries to be open to this sharing. On the other hand, you know, needs reward for the innovation. So it's not black and white, it's a bit more grayish. We try to somehow not to be fragmented, despite the fact that the competence is not there, despite the fact that we are 27.
Mm-hmm.
But on clinical trials for the Biotech Act, I hope you will then support you all this request that we have, that the country that is the rapporteur in EMA for the medicine, so for the authorization, will also be the one with the ethical committee and, you know, trying to do that clinical trial on the basis. I think other member states should trust that country. And, you know, it's a well-known fact that ethics is very difficult to manage. It's like nitroglycerin, so I may be disappearing in a minute. But it is true that the multifarious numbers of ethical committees we have in Europe have created the opportunity for other companies from outside to come and produce a clinical trial with our own patients, circumventing a bit what, because
a little bit of
as she was saying, clinical trials are the only hope that some have.
Yeah.
This is important to remember. There's a life or death matter for some.
Great.
So I hope it
Thank
was
you.
not too incendiary, but you know,
No, it's
I
the
think
reality. It's the
Europe
reality
will
with everything
stand
that
as a
happens.
leader in pharmacy, because we have the hands, we have the brains. What we don't have, the good scaling up, the time to market. Time to market
And the
is
structures
lousy.
to
It's
allow that.
lousy. We need to improve on that, but we will. We will, if you
Well,
help us also.
Thank you.
Industry
Thank you,
needs to
Sandra.
help.
Thank you, Sandra. So we're running out of time, so I'll take 3 questions from the aisle. Okay, maybe 4, very quick. We'll start here. And then we'll go for a final round.
Thank you so much. I'm Meita Beholder from the European Heart Network. So I wanted to bring back the conversation a bit on prevention. And my question is more of a request for reassurance, because I heard a lot about older population, which is very much fair. But I missed a bit the focus on younger population for 2 reasons. First of all, because I think we should be way past the point where we think that stuff like, I mean, communicable diseases, no-brainer, but NCDs as well, they do affect young people as well. I'm a living proof of that. And they're detected too late, and prevention can also help there. But I mean, if we're talking about older population now,
Please,
and
to
yes,
the question,
yeah,
we don't have
yeah,
time.
I mean, the next generation will be exactly as this one if we don't tackle it early. So yeah, request for assurance that this is in the radars. Yeah, thank you.
Okay, so how to include young generation? Please, gentlemen there.
Thanks very much. My name's Rory. I'm a health reporter at Politico. My question is for Sandra. You mentioned the pandemic agreement. Does Europe need the pandemic agreement for its own prevention strategy? And if so, is the Commission willing to move further than it has already in the negotiations with low and middle income countries, and how far? Thank you.
Thank you. Next one.
Hi, good afternoon. Sibilia Quilici, representing Vaccines Europe as part of FPR. I've got a comment and a question to
Just
Sandra.
to the question, please.
We need a bit of background because we didn't touch about the whole value of prevention was clearly identified in the panel, but how to ensure that we have sustainable prevention plan and strategy within member states with appropriate funding. And here the funding is really an important component of it. You mentioned the issue of funding with regards to less than 3% of investment by member states. The Commission adopted in 2024 the new economic governance framework, which provides a possibility for member states to invest in area of growth while maintaining discipline in their fiscal sustainability. 4 priorities identified by the Commission: green, digital, defense, economic and social resilience. How is the Commission seeing this as an opportunity to invest in health promotion prevention, and how it aims to collaborate with member states in order to make this happening?
So linking health with competitiveness. Okay, we'll take the final one, please.
It works. Hi, I'm Sarah Dastoum. I'm from Cienzano, the Public Health Institute in Belgium. So I was wondering, when we talk about prevention, we often talk about vaccination, diagnosis tools, and, for example, reducing alcohol consumption, but we often don't talk about the diet and the importance of the healthy diet. How do we expect to prevent NCDs when the healthy diet is not accessible, it's expensive, and on the other hand, for example...
Okay. Yeah, healthy diet. Thank you. Thank you. So we'll start here. Maybe we'll start with Casper, and we'll go...
Yes, thank you. I wanted to address the prevention side of things, and I think that's really a key issue, because it's all about keeping people out of the hospital as much as possible, or getting them out of the hospital as quickly as possible. And here we are really seeing, we also want to look inwards sometimes as an industry in our case, to say how can we actually help looking forward in trying to push this. So it's not always just saying you are not making the incentive, but we also have to come up with the business model, right? So just one example, we are, a lot of us, especially younger people, are starting to wear devices. We are actually monitoring ourselves and creating our digital twin. We discussed that last year at this summit. And one of the interesting things on my own app, it says push to your healthcare professional, right? My healthcare professional cannot receive that, right? He simply doesn't have the interface. And there, for example, we are pushing our members to say, are we the ones who are supposed to build this? So there's definitely that aspect, and it ties in with the diet as well. And I think very crucially, health literacy. We've been speaking about that for many years. It's been a very difficult task. It's all campaigning, and that campaign by definition is more or less one-sided, right? So it kind of has to be a one-size-fits-all. I think really, and I'm sorry to say so, but AI is revolutionizing this. It's revolutioning our health literacy, both because we're talking to AI, but also because we're talking to our doctors and challenging and back and forth. And it is challenging the authority of our healthcare professionals and so on and so forth. So one of the things we see, for example, is curricula in med school, pharmacy, and so on, probably has to change as we move along.
Exactly.
We see more and more pharmacies telling us, well, actually, I get a lot of questions from young people or all kinds of people, what devices are best, or what apps should I use, and stuff like this, which we are not currently, capable of. And again, here, many of my members are cooperatives of pharmacies. Maybe we have to set the foot forward and say, this is it. Yes, create that market. So I really believe that when we talk prevention, we are actually starting to see the tools for a revolution where with health literacy, actually going up, actually, and individualized, so that you can also find a healthy diet using products that are still affordable, because I acknowledge that problem. So I will just say that we also take that on ourselves, yes, and as industry, we have to think new ways as well and come up with those models, and then I hope we will have the ears fully open so that we can actually implement it.
Oh, thank you. Minister.
Yeah, first of all, I think it's important. I think data will be really the way forward now, and we are a changing world. And just on young people, like 10 years ago, for example, vaping was never an issue, but now vaping for our young people is absolutely huge. So now I'm bringing in 2 bills on legislation to dispose of single-use vapes, but also the colour, the packaging, and the flavouring. We wouldn't have had this 10 years ago. So the realities are here. We are a changing world, and we are constantly changing. And that is the way we have to move. So I firmly believe that our data going forward, working with our other EU countries, will absolutely be crucial here. And that's how it goes. Obesity is another area. Absolutely, we need to look at obesity, communication, awareness, what people are eating. We look at areas maybe that are more deprived, how we can look at the areas where we can work with. So there is all these challenges, but we are changing. And I think for all of us here today, we've learned this now. maybe next year there could be something else different here. So we have to keep changing, and for us to make those changes, we have to be really working together to do that as a collaborative approach. Thank you.
Well, thank you, Ray.
Yeah, I think one thing that I would like to add on, it speaks to one of the questions we had here. We need better fiscal flexibility and seeing health and medicines as a long-term investment and not a short-term investments. Because if we invest in medicines for patients, we can absolutely increase life expectancy. And we need that investment a little bit longer term, because it takes a bit longer term to get back return on investments when you do, for example, detection of chronic disease and treatment. It actually pays back very well. There are new data showing every euro you invest, you get almost 5 back on chronic diseases. If you say immunization, is even more, is 19 euros back on every euro invested. So, but you need a little bit longer term and see this as an investment. And that's so the MFF plans that are now coming into place, we could see medicines can play a very important role and give the flexibility that member states need.
Thank you. Sandra?
Thank you. Different topics. So on the funding part, I would simply say that Europe has learned the lesson. We need to finance health, and there is the European Competitiveness Fund with a window for health, which has also other stuff in. And I would say it's very important to realize that for an agenda in terms of prevention, where you have also the younger generation included, let me say that we have this program that is called Healthier Together, not by chance, because it's together all generations, so not just the final ones. And that would be totally detrimental, because it's your prevention needs to start very, very early. So I'm happy to see that we somehow are vindicated that there is also attention on that. Of course, in terms of member states, many votes come from the aged part. So this is why there is a lot of perhaps rhetoric going around the older part of the population. In terms of, I would say, the possibilities that I see for health in terms of a possible market or a possible, the fact that there is not a single market and so on and so on. I would suggest that we stop thinking of medicines as arriving to a patient like any other goods. There are many steps. There is the industry has to make a choice on where to invest it. That is already the question of Sibylla is, will you be supporting? I think Horizon Europe is still there, so there will be a part of research that will be financed through that. Then, you move on, and there are many actors, not just EMA, if it is centrally authorized, but, there are many actors before the medicine arrives to the patient. So, in a sense, to align all these stars for the patient to always benefit from the highest innovation at the right time, at the right moment, requires a lot of work also from the member states. Allow me to say that praise goes to them that have to run health systems with regional competencies in some cases, not just national ones. So be careful when we think of medicines arriving to a patient. It arrives after many, many steps.
Of course.
The last mile perhaps is the doctor, And so just to say, and to conclude, fully committed on the pandemic agreement. We were the ones proposing it, so it would be paradoxical. Even the question is not the one that I should be receiving. We are fully committed, and the last big concession that the member states accepted was simply to say, okay, even the sharing of the pathogen can be simply voluntary. So countries of the global south are under no obligation to share the pathogen if they have it. This is a lopsided situation, because there will be an obligation on the north to give, I would say, the medicines 20%, I would say, of donations, but there will be no obligation to share the pathogen. So, in fact, Dr. Tedros and the other brokers in this agreement are actually waiting also for a step from the others after this big, massive concession. And again, praise to the member states that are ready to embark on this agreement, you know, and really complete it. It's a very important piece for the world, as we have seen recently with Ebola.
Yes, thank you, Sandra. Last word to Delphine.
Thank you. I'll keep it short. I think it's really important to underline that health and youth are words that are not easily combined. I mean, I couldn't help but writing down the number of 85% of the cost of healthcare occurred in the 15 last years of someone's life. And so it's really something that we see when we are advocates in the field of pediatrics. It's very hard to raise awareness on the specific issues. And the specific issues like the lack of innovation in pediatric oncology are exactly the same in other disease areas. And there's even worse than pediatric, there's cancer in young adults, because they really fall between two chairs. Older people get cancer, it's very common. Children have pediatricians looking after them, they know how to work together, but there are no doctors looking after the young people with cancer. And so the health data systems is really something that we should get use of to understand what diseases affect the youth and what are the trends. And it's really something I'm hopeful about. And based on this data, at the European level, we should encourage collaboration between healthcare professionals and between patients' organizations to make sure that we get a real network of people taking care of the youth. Unfortunately, as you know, the operational grants for patients' organizations were cancelled in the EU, and it's very unfortunate because there isn't much money, you know, from the general benevolence to fund lobby work, and I'm privileged because we fund mostly research and activities for patients, so we can also invest in lobby work, and people know it, but it's not what they really want to fund as part of the work that Key Cancer does. But lobby work representing patients with the governments and with the European institutions, it's key to drive progress. So that's also something that I wanted to underline. And finally, when we talk about prevention in young people, survivors from cancer, and it can be pediatric cancer, but cancer in young people, these are people who survive or will have a long life. And so having a diabetes as a result of the cancer the person had when they were 12, or having a knee replacement or hearing impairment, there's something that will impact their whole life, and it will need a comprehensive treatment pathway. And so creating dedicated places where young people can be followed up, you know, when they have multiple pathologies, is also something that should be put on the agenda as a treatment, but also as a prevention option, because the earlier you seize the disease or you identify it, the better it will be treated.
Chances. Yeah, absolutely. Well, thank you very much. There were so many good things, great ideas that came out of this panel. I wrote down so many keynotes, but maybe I'll just conclude with cooperation that was mentioned across, you know, governments, between countries, between industry and governments and civil society. So great point. So as we then come to the close of this summit, and I think we are almost on time, I'd really like to extend my sincere gratitude and thanks to all participants, to all the speakers. Thank you for the amazing job. Organizers and partners that made this summit possible and have contributed to the success of this event. Over the course of the 4 panels that we had this morning, we tried to touch, there was not enough time, some of the most pressing challenges that we see in Europe, but also some of the promising opportunities. We should not forget about opportunities in the healthcare today. The insights and recommendations that emerged, hopefully, you know, we have captured them well, and we can use them to see where we are and what's going to change over the next 12 months. So when we come back for the next summit here at Friends of Europe. So final point from me is that throughout the 4 panels, this summit reminds us that progress in health or progress in reimagining the health system in Europe is not achieved by one institution, it's not achieved by one sector, by one country or industry alone. It really requires, as Delphine was mentioning, collaboration, innovation, and a shared commitment to everyone. So with that, join me in a round of applause for our excellent panel. And let's keep talking together all across the different sectors on these important issues. Thank you.
Well done.